As usual, we'll go through our normal little intro and then we can start with our agenda. So this meeting is being held virtually and is hosted by the Utah Department of Health and Human Services, Center for Medical Cannabis, based in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah's open meeting laws and was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting is being recorded. The recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. A rough draft copy of the unapproved minutes will be posted to the Public Notice website within 30 days of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after the board approved. Every proposed agenda item must have a 1-page summary of the topic submitted to the Policy Advisory Board no later than 7 days prior to the board meeting. Board members will present a 1-page summary during board meetings, and board members will discuss the summary. If no written summary is provided to board staff, the relevant agenda item will be removed from the agenda. Only items that have been submitted in writing in advance of board meeting will be allowed or any discussion by the chair, including presentation of board members will then request additional presentation and memorandums on agenda items and relevant bodies to be presented at the next board meeting. Those presentations and memos will also be submitted to the Policy Advisory Board 7 days prior to the board meeting. So for this meeting, the memos didn't get completed 1 week ahead of time. We'll do our best to get that changed for the next meeting. Obviously, when Trevor taking a bit of a different role, we had to figure things out as we go along. I will say it was much more helpful when Trevor did a lot of this and assisted us with this. That's pretty challenging. Majority of the policies put on the board members, but we will figure that out. As it relates to public comment, public comments will be limited to 2 minutes per person. If you want more time, you must request it from the chair. Chair may accept or reject requests for additional time. Public comment period is not guaranteed every meeting. The chair has the authority to create or remove public comment period from the agenda or during the meeting. You can look over public comment guidelines as posted on the Utah Public website. When making a public comment, please state your name and your affiliation so it can be reflected in the meeting minutes. Only comments made on items listed on the agenda will be considered. If you have a comment about an item not listed on the agenda, please email them to mcpab@utah.gov. For those making comments over Zoom, we've made a small change. There is no longer the form to fill out. So public chat will still be disabled during those Zoom meetings. However, instead of filling out the form, when it's time for public comment, you can raise your hand by using the raise hand icon on Zoom to indicate that you'd like to make a comment. When you're called on, you can take it off of you, and then we'll take 2 minutes to make your comment. For those here in the room, please sign in on the public comment sign-in sheet, which is down there. If you'd like to, with your name, and indicate what agenda item you want to make a comment on. The chair will indicate when it's time for the public comment period. The board chair will call on you when it is your turn and you will come to the public comment table. Please take 2 minutes to make a comment. Also, please try not to repeat comments that others have made. Please try to add your comments. As a reminder, if you are in person, please do not speak when others are presenting. Our mic is very sensitive and those attending over Zoom cannot hear when there's more than one person talking at a time. Side conversations and comments from the public during this board meeting. Okay, we will move on to item number 2 on the agenda, approval of the March 2023 minutes. Has everybody had a chance to review the minutes? Proposed changes.
Chair, I make a motion to approve the March 2023 minutes.
Okay, we have a motion to approve the March 2023 minutes. Do we have a second? Okay, we have a second. All those in favor, please say aye. Aye. Any opposed? All right, I find that motion passes unanimously. All right. Administrative business. I don't know if there's a whole lot of administrative business other than kind of some of what I had talked about, in relation to the memos. They're going to be created for future board meetings. It has been a bit of a switch up since our last meeting. With Trevor taking on more now a research role. He is not doing as much substantive writing for us. This is coming from either members of the public or members of the board. So I think that it's probably warrants, some discussion, at some point. I know during last month's meeting, several people expressed, support for Trevor continuing to not only research the memos, but to write the memos and present them. I found that this month, because I was involved in two of them, that I think it's important to make sure that the board members or the members of the public, wanting the item to go on the agenda are involved. And maybe they do some of the substantive writing. But I think if we want these memos out quickly, I know this isn't Trevor's only job, but I know it's one of the primary things he does. So, just wanted to throw that out there. It might be that we just stay with, with what we did for this meeting, but I do know, it was very, very helpful. And maybe what comes of this is when we have a discussion, we make sure as part of that discussion that we assign, research topics to research. So we can have a little bit more, direction for him writing after the meeting, so that he can complete his research and then whoever's proposing the agenda item and then go to write them. So if anybody has any thoughts on that, we're happy to hear it. Otherwise, we can move on. Okay, we will move on to item number 4. We'll start with any updates from DHHS. Rich?
Yeah, great. So as of March 31, 2024, there are 83,421 active medical cannabis card holders. That's something that was posted on our website in our monthly report that appears on there for the previous month, just in that first week of the next month. And also 950 QMPs that are registered and 77 pharmacy medical providers that are registered in the program. And there are more statistics available on our website that you're welcome to look at. Also, I felt it would be helpful to share just a few quick stats related to compliance. One of the responsibilities that we have is to complete audits of the program within the context of the responsibility that we have. And so we perform audits on some of the operations that the QMPs have, some limited operations that the pharmacies have within our responsibility. And for example, when a QMP applies for a medical cannabis card, or not a medical cannabis card, but for their registration, we check on certain things to make sure that everything is there, and we audit those applications. Also on medical cannabis cards, when individuals apply, we ensure that we can follow up on a certain random group that telehealth visits have been are only completed in those subsequent visits opposed to the first one. Those should be still in person. That's an example of a type of an audit that we do. Also, patients with PTSD, that's a qualifying condition, but it does have some specific requirements that apply to it. And so we do follow up with QMPs that list that as a random sample and ensure that that is being complied with. And it involves a lot of education. And then if we notice that there are patterns of non-compliance, we take further actions. And in some cases, we've had to take away a QMP's registration because there's something that's happened that causes them to be out of compliance, and there's a pattern of it. We also received 11 complaints during the past quarter, and those relate to several things such as advertising that may have that a QMP engaged in that may have violated the law, and there's a few others that we've received as well. So total audits that we've completed reach over 5,000 during the last quarter. So those are looking at specific records to confirm that they're actually meeting the statute. And then we have an average compliance rate of 95% during the past quarter, which I think is remarkable. That means that that's a good sign, obviously, that there's some compliance happening, but obviously we want to also focus on those cases where there's non-compliance happening. So that just gives you an update as far as compliance goes. We sent out our quarterly update from the Center for Medical Cannabis earlier this week, and so you should have all received it. And if you haven't, just let us know, but that provides very useful information regarding, for example, a meeting that we have coming up on April 23rd from 9 to 10:30 a.m. This is a virtual meeting that the CMC is hosting. It's intended for medical providers, for pharmacy medical providers and medical cannabis pharmacies, and stakeholders to help them learn about some of the new medical cannabis laws that are becoming effective beginning on May 1st. And also we'll be covering details regarding the new PBS software changes that will go live by the end of the summer. So that'll be a virtual meeting, and there's the link is within that quarterly update. And we've also sent this out to QMPs in the state so they can join if they choose to, or have their staff join. But it's not a public meeting, but the link is there for anyone to join if they choose to. Also, QMPs can recommend medical cannabis to the number of patients that's equal to 1.5% of the total number of registered medical cannabis cardholders. And that is updated each quarter. And so the patient cap right now as of April 1st is set at 1,252. And so that's been updated in our system, and we're holding that limit in our system, and QMPs have been made aware of that. And then we do have a presentation that I'm going to be a part of coming up on May 16th. That's before the Ogden Surgical Medical Society. And a number of physicians will be attending that. It's titled Medical Cannabis in Utah Law and Key Aspects of Physiology, Pathology, and Pharmacology. And I'll be covering the law, and then Dr. Matt Kitt will be covering the clinical side. And that's from 2:30 to 4:30 on May 16th. And because it's a part of this medical society conference, there is a fee to attend that, but any medical provider would be able to go and attend that. We're always excited to share more information about medical cannabis and settings like that to groups that may not have heard a lot about those topics. And then some of you at our last meeting, I think I told the group about a University of Utah School of Medicine webinar that was held on harm reduction in cannabis. That was well done. A few of us at DHHS were able to join that and listen in, and it was recorded, and it's now available on the University of Utah, their website. So a link to that is in our monthly update, so you could go on your own time and listen into that. That's some evidence-based harm reduction information that we felt like was helpful to us, and we feel it would be helpful also to the industry and to medical providers and pharmacists that work in the industry. The Cannabis Research Review Board meeting happened earlier this month or last week. And if you're interested, the minutes will be posted soon, and you can kind of review what topics came up during that meeting and learn more about what the latest is that they are talking about. One thing I know came up, Misty, was the screening tool that the board was working on. And I know that there was a handout that we hope medical providers find helpful that was reviewed and discussed. Any other items, Misty, you feel might be good for the board to know about that came up during the Cannabis Research Review Board meeting?
There were some items discussed, but not formally prepared presentation yet.
Okay,
So perhaps at the next meeting,
great.
communication between departments, but nothing is formalized yet.
Okay, great. So that concludes the DHHS update. Thank you.
Awesome. Thanks, Rich. Brandon, turn it over to you.
Great, thanks. Just thought I'd give a quick update on the THCO acetate situation. It does seem that we've been able to see a drastic reduction in the amount of THCO acetate in products with some pretty minor adjustments to the processing of those concentrates. And it seems like just reducing the amount of time that it's experiencing heat is having the effect that we all kind of thought it would. That's great news for industry. It doesn't seem like any major equipment purchases were required to do this so far, and we hope that it continues. There was an error discovered in the testing on a limited number of the samples that failed for testing. Or for THCO acetate, it was discovered that there was interference with the THCO acetate in their method that we used to quantify it. So 4 of those test results were overturned by our laboratory, and those products were released and able to go to the pharmacies. They were discovered to have no THCO acetate in them. These were more or less live rosin. So that was good news. It brought our total failure rate down by about 4% of the products failed. Everything else has been able to go out to pharmacies, and processors again shown good progress in getting this out of their products entirely. I'll turn a few minutes over to Cody to give a rules update. The legislative changes, we're going to be making quite a few rule changes.
Yeah, thanks, Brandon. As Dr. Forsythe mentioned, we are working on rules pretty heavy right now, and hopes to be able to get a number of them to this board for review next month. But I'll just go through kind of the rules really quick, which ones we're working on. Cannabis cultivation based on legislative, there's not really a need to look at that rule. However, as we're doing some looking at the possible of radiation use, cultivation might come into play on that. We'll like maybe have some ideas, and as I mentioned, bring it forward for you guys for review based on how we continue to talk about it internally. Cannabis processing is going to obviously have some changes. First and foremost is going to be targeted marketing, which was allowed by statute this year, that will go into effect. Statute go into effect on May 1st. So we're working on that wording. That's really the big thing with cannabis processing, and obviously radiation, if that's something that goes forward, would probably be in there as well, as far as some labeling aspects for products or flower that has been radiated. Quality assurance testing is the one that this group brought forth to them last time, or with an emergency meeting for the emergency rule. Obviously, that emergency rule is in place. There'll be decisions on if we want to just have that emergency rule go into effect full time, or how that looks. There's also a discussion based on some input from some other doctors and from the lab that possibly want to make some small changes to quality assurance testing for the microbials.
Yeah, microbial.
So we haven't really started on that just yet, just worried about the emergency rule, so haven't really dove into that just yet. Educational event and education material rules will probably start working on. That's not a legislative one, so there's not necessarily a time frame on it, but we'd like to add some pharmacy stuff to that to keep it all in one rule versus having separated into a couple different rules. So it's just really kind of adding some old language to that one and removing it there. Probably the big thing is medical cannabis pharmacies. There's a portion in the statute that wanted us to truly define the regions within the state. It also has some closed door pharmacy language you got to work on that. So that's actually the one that we're currently working on pretty heavy. We started a review of that the other day as a team. I think we probably got through about 80% of it. I'm good with what the language we had submitted to the team first, and then needed to work on it a little bit. So hopefully by Wednesday, by tomorrow afternoon, we'll have that draft pretty good. We can definitely maybe send that one to you guys in the future. But yeah, a lot of rules being worked on based on legislative changes, and then hopefully we get her done correctly and quickly.
Given the both of the pharmacies and then we'll be able to issue 3 of those, by 2027, do you guys plan to have some sort of formal like application process where like all applications will have to be submitted by a certain date and considered?
Yeah, it will be a process.
Do you have any idea when that would start? Is it going to be this year or next year?
Likely this year.
Yeah, first and foremost, we got to do is get those regions put into place, and then we can start looking at those aspects of the closed door pharmacy. The closed door pharmacy, we've probably got a number of ideas put down, but the language itself is still unknown at this point. So
We'll also be going through renumbering the rules for medical cannabis. And so the content won't change on those, it will be substantial changes, so we don't plan to bring those to the board other than just letting you guys know what the numbers.
That's correct, and that'll happen on May eighth, when that'll be in effect, and then, so any of these changes that we are gonna do with rules, we can't even submit them to the rules until after the numbers have changed on that, so.
All right, and then lastly, from the Department of Ag, wanted to talk about the market analysis survey that was the market analysis that was conducted this year in partnership with Canada Public Policy Consulting Group. You should have all received that this previous week, and happy to answer any questions that you guys have on that. I'll just point out a few key things in the market analysis. The average amount spent on cannabis in the state, as noted in the report, is about $110 a month. And that's pretty consistent with what people are paying all across the United States for medical cannabis specifically. One thing to keep in mind there is that amount does not account for the grants purchased, it's just the total amount spent. So if it's more expensive in our area, the patients are getting less for that dollar amount spent. Some good news from the report is that patients do seem to find value in paying cannabis from medical cannabis market, indicating that they're willing to pay more to get it from a pharmacy at around $12.15 a gram on average. There's pretty high error bars on that, but the average, they are willing to spend a bit more to get it from a pharmacy than from any other source. Which is really good news for us. We do want to make sure that the medical cannabis market is viewed as having a high quality product that is suitable for use as a medication. A little bit, well, one more, I think bright spot in the report is that about 60% of patients feel that there is an adequate supply of medical cannabis. And then about 35 say that they felt that the supply was limited. So between those two categories, it does seem like patients feel that there is an adequate amount of medical cannabis within the program at this current time, which is good to hear. A little bit less good to hear is that about 25.5% of respondents said that they felt, or well, were going out of state to obtain at least some of their medical. And even worse, that matches more or less what the regular market non-patients are traveling out of state to get their cannabis. So overall, the program doesn't seem to be limiting out-of-state travel for obtaining medical cannabis, which is unfortunate. And there are various strategies that we may be able to use in the future to try to get that number down. It's not significantly, well, it is significantly lower in other states, with around 22 being the average in other states. So I think we do have some room to go down, but there's always going to be some number there of people that are just going to travel out of state no matter what. I would hope that that number is considerably lower within the medical cannabis program than just your average consumer market that's looking for cannabis, but during times that's just not the case. The major driving factor for that seems to be price, with the cost in Utah being higher than it is in neighboring states. And it's important to qualify that by saying that we're pretty competitive price-wise with other states when it comes to medical cannabis. But recreational, you can obtain this stuff right across the border to either the east or the west at pretty reasonably priced. So those states really, Colorado and Nevada, I guess I should specify, really do have mature recreational use markets and get stuff pretty cheap there. And it's not that far of a drive. So the program's always going to have to contend with that at least a bit. But it does seem that patients do have that perception that the cost is too high within the state. It doesn't seem, they did see a correlation in drive times. With the farther someone had to drive to get cannabis, the more likely they were to go out of state to obtain that cannabis. And not much of a correlation with the number of pharmacies in their immediate area, which is kind of an interesting dichotomy there. But I think it does show that once we get to a certain saturation level with pharmacies in the state, it really doesn't matter unless adding those pharmacies does improve access and increase drive times, which is honestly not surprising to us at Department of Ag. It's what we suspected and why we started doing drive time analysis last year. With that, happy to answer any questions or hear any comments from the board.
I did have one question about the survey itself. Was there a reason why you guys chose not to look at access from, human perspective, cost of cards, how often you have to renew cards, from
Not
access
in
perspective?
particular, they're the Canada Policy Consulting Group, Public Policy Consulting Group had their list of survey questions already outlined, and that wasn't necessarily included in there. So it wasn't as specific. Not that we didn't want to look at it, and we can suggest things for future surveys, which that is a good look at.
Any questions or comments from anyone else? I guess the one other question I had is, are you guys planning to use the same regions from the analysis in rule? How they identified the different, 4 different regions they identified in the
Yeah.
analysis.
No, we're likely to come up with new regions.
To replicate this survey in the future, so you can
Yeah.
find some changes.
I don't know that for sure that we'll go with Canada Public Policy Consultant because we have to go through an RFP to do these things. But I think having an outside third party look at the market is demonstrates better non-bias. The department's not putting our finger on the scale. We did see some drafts of this before it came out, but only noted for technical and other, would like to see more data here and there, not necessarily, not absolutely not asking to change it to the findings or anything like that. If anybody who wants to see the drafts that they send us are welcome to see those as well. We don't want to have a finger on the scale here. We just want the data and to make sure that we can respond to that information that we receive in a way that benefits patients.
It may be a good opportunity for interaction with the Center for Medical Cannabis to do and use their resources in terms of population health.
Yeah.
Too.
Questions, comments from anyone?
Question for Rich.
Yeah.
Rich, looking at the number of active medical cannabis card holders, you've seen quite an increase over the past 6 months, 11,000. New cannabis is about 14%. Anything that you can attribute that to, or you can add to that increases occurred?
I can just share a few factors that may have had some impact. One is the change from 6-month cards to being the default to 1-year cards being the default. We haven't yet seen the total impact of that. But at least some of the impact, I think, has happened from that law. You would expect that there would be less expirations of cards with that. Also just around the state, more people becoming aware of the program. And I think the federal government addressing the topic more than it has in the past, although still illegal federally. It has been an issue that's been mentioned more in the media than in the past. So that could be another factor as well.
Yeah, like 3 months prior to that, last 6 months, you saw about a 1% increase. So I think we're like that 6 months a year, maybe sort of play that out. Usually for a year from now, you're still seeing the same levels of increases.
Yeah, we'll track that and we can share that data with the board.
Thank you.
All right, anything from anyone else, or should we move on to the next agenda? Okay. So item number 5 on the list is regarding card renewals with the pharmacist. If you guys remember, I'll set the stage a little bit, and then I do want to I'm going to turn it over to Des to do a little bit of speaking as well. But last month we discussed the idea of a collaborative practice agreement would allow, a PMP under a collaborative practice agreement with a QMP to renew medical cannabis cards. This would not be something that is required. It would be something that is optional between a QMP and a PMP if they wanted to enter into that type of an agreement. So we discussed it last time. There was obviously some discussion between Dr. Morgan and Mindy from Beehive regarding some specifics. But what we did is we put together a little bit of a memo in a presentation, just regarding for myself and for Des, some help from Mindy and some research from Trevor. And again, this is not something that would simply require this. It would just make it an option for those QMPs and those pharmacies who wanted to go that route. So I just want to make sure that that's something that we highlight. But with that, Des, if you'd like, we can go ahead and present on some of this, and then I can fill in some holes if you'd like.
I was on mute. Okay, so let me get back to my agreement here. For starters, the reasons why we have come to this, in the beginning of this proposal, we talk a little bit about the background. The biggest thing that I think made everybody look at this is in this very first sentence, you'll see that just over 46,000 patients have chosen to not renew their medical card at some point. Some of them have renewed after having a good amount of phone numbers from people that have applied for the program and then the subsidy program. Sometimes we'll go to approve them, and then as we go to approve them, they are not, their card is no longer active. And so I've asked a lot of patients, like, why is your card no longer active? And my number one by far response was that they could not afford to renew. They could not afford to go back to their physician to get the card renewed. It wasn't the cost of medication inside the pharmacy, although that's an issue. They were like, well, I can buy a cheaper product or whatever. It was almost always that they could not afford to get the card. I did have some patients come to me and say, okay, so brutally honest, I have 3 people in my family that use the card, that need a card. And so one of us will renew and they'll just buy product for everybody because we already know we have they have qualifying conditions. So it's like, they now believe that they have a condition, they qualify, but they just can't afford getting, 2 or more or even one person back on the program. So that's how it kind of started. And our goal from the beginning has been, patients, not criminals. So we have created a program. We say you could be a patient. Now the barriers to entry are kind of weeding out the poor in a lot of ways. So there's our problem. So there's where that's kind of our starting point. So, we did a couple things. We created the cost compare website, and that's one of the things we talk about in here. So you can get on there, and according to that website, and that's not really accurate, but it says, they're anywhere from $10 to $500 for a card annually. A lot of the $10 fees, when I called, it's almost like a subscription. So they have to pay like $10 a month. So on average, it's about 190 if that's for one card in, if you have one person in your family. So again, so all of that, and sorry, you just have to excuse me, I have like the worst migraine, so just bear with me as I stutter and can't really read. But that's how we ended up here. The proposal was, and this came after a long time of just discussing with people in industry, with patients, and then recognizing one trend that happens over and over and over. And this trend is that a patient will go to their, a lot of times, primary care physician. Primary care physician does not have their QMP. And so they will find a QMP for their patient and then send them there. And then the patient on average, $190 to $200 pays for, at that point, just pays for them to get them on the EVS system and get them their card that way. And a lot of times they'll walk in to their QMP with a letter from the doctor that says, hey, will you give my patient a card for pain? Sometimes they just go in with medical records. And so they're literally like delivering the diagnosis to a QMP. Now, I'm not saying that happens all the time. I'm saying it happens a large enough amount of time that I think that we need to find a solution. We started kind of taking that idea. We created the LMP program with that. It didn't really take off as much as we were hoping. I think through kind of lack of education. So we were looking at a collaborative practice. When you break it all down, the pharmacist is already doing majority of what the QMP does in the visit minus the diagnosis. So in these situations where we don't have to have a diagnosis, would it be appropriate to enter into a collaborative practice agreement, which would mean that the primary care physician or the QMP or whoever has done the original diagnosis that says you need medical cannabis, they take that documentation to the pharmacist. Now, the pharmacist is already trained in the EVS. And when I talk to a lot of these QMPs about why their costs are so high, and QMPs are, I'm sure, can speak for themselves, so I won't go into that very much. It's the EVS. It's paying somebody to manage that, to get people into the program. The EVS is kind of hard to handle. And so pharmacists are already doing that. They already understand the medication. They already can research diagnosis codes. They already, by law, have to meet with the patient and talk about their diagnosis, talk about what medications would be appropriate, look at contraindications. They already are doing that, and they're already the ones that are following the patient most closely while they're in the pharmacy and talking about medications every time they shop. Is this working? Do you have any questions? And so because of that, we were looking, is there any way that during some situations, could we enter in a collaborative practice agreement where the recommending doctor enters in this collaborative practice and the pharmacist gets them onto the EVS, they check the diagnosis codes, and then we just remove that necessity for that $200 payment or $190 payment, and get the patient on and keep the patients not criminals, keep the patients that are actually using cannabis in Utah or deep roots, keep them on the program and keep them incentivized to be able to purchase here in Utah and have a legal reason why they have medical cannabis in their system for their job or for if they're driving or, just for our ability to track conditions in patients. If we're not incentivizing people to get their cards and we're not removing those barriers for them, it pushes them into other industries. It pushes them back into the black market. It pushes them to deep roots. And so how can we do this in a way that they still get the coverage medically, they still are being tracked with a professional, and I think that this is a pretty good solution. JD, what else do you want me to say? Do you want me to go into the whole proposal?
Yeah, if you want to, I know we're gonna have some public comment, and we also did get a letter that was addressed to the board that I would like to address some of those things. If you want to cover, I think you've covered a good portion of the proposal, but if you want to cover some of the rest of it, I can then chime in response to the letter that we received, at least from my perspective, and then we can open up to public comment. So if you want to just work your way through the rest of the proposal and make the proposal, then we can.
Okay, so I'll just go a little bit more into it. So as you see that it says all 50 states have legalized collaborative practices. This is something that Utah does in pharmacies as far as things like ear infections or strep tests or vaccines. So this would just be adding cannabis like renewals onto that. And so it'd be something that wouldn't be that far-fetched. Again, it was just saying that we could optimize the process of recommending medical cannabis, lowering those associated costs. And truly, you know, I work with the subsidy patients, and so I see the patients that are choosing between paying for medication or paying for food. And this is the biggest barrier. They're choosing, am I going to pay for food? Am I going to pay for rent? Or am I going to get my medical cannabis card? I will say that one of the hardest days that I've had during this program was one of the patients calling me and saying, I'm so excited. I've gotten my card. And I was like, that is really exciting. And we were talking about it. And he goes, I had to move into my car, but I'm a legal medical cannabis patient. And he did. He moved into his car and he lived in his car for almost a year, but he was so proud to be able to be a legal medical cannabis patient. And I got to get off the phone with him and think to myself, I did that, right? I created a program in which he could not afford his rent and be a legal patient, but he had been to jail before and he was never going to go back. And the fear of going back to jail and losing his job and losing all of the things that he had done to get back on his feet was not worth the risk. And so, while I talk about this, I just want everybody to remember, we're not talking about me, right? I can afford the $200 if I have to do it. I could not, however, afford it for 3 people in my family if I needed to do that. So I know that there's a lot of emotions here, but these are the people that we're trying to avoid going back to choosing between patients and being criminals. So underneath this model, the RMP would renew the recommendation, and it would be completed by the PMP at a reduced cost. We have talked to a couple pharmacies where the PMP would be handling this, and we can't set their prices for them, but we can assume, and with the ones that we've talked to and the other ones, that the prices would be much lower because their income isn't associated with giving a renewal like a lot of the QMPs. They don't have to pay for insurance, so that's a drastic cut in cost. They don't have to pay to have their business license. All of those costs that raise the QMP cost are reduced. The pharmacist is also already has a license that they don't want to jeopardize. So I think that the risk of them doing something inappropriate is low. And I think that's one of the only true concerns when I've talked to some of the lawmakers, is just making sure that separation is there. And I do feel like that is low. It would have to be an agreement. So the physician would always be in charge, just like in the regular program. They could agree to remove it at any time. And so if they enter into this collaborative practice and then maybe the pharmacist isn't responding, or the QMP or the RMP feels like they don't want their patient on that anymore, they can still end the agreement and cancel the cannabis card at any moment. I think one of the benefits would be it streamlines the process. The collaborative practice agreement, it simplifies the recommendation process. It reduces the administrative burdens for the patient and the healthcare provider. Each patient is already required by law to be evaluated and educated by their pharmacist before they're allowed to purchase. That would continue. So that's something that, like I said, it's already happening. I think that there would be a little bit better, sorry, again, the migraine, they're just a little bit more competitive practices going on with trying to keep cost low. It would be, the pharmacist would have to answer to that a little bit more than the QMP does. When they're shopping, it's like, hey, if I go over to this pharmacy, they're only going to charge me $20. So I think that they could work around cost a little bit easier and kind of compete for keeping fees low. But, again, it's not going to add that much burden to the pharmacist to ask that they enter into these agreements with physicians, because they're doing most of this anyway, and they know how because of the schooling that they did to become a pharmacist. Let's see. Oh, just again, we've recognized through this program that the physicians have really become the specialists here in Utah. They are managing these medications every day. They're learning about the new medications. They understand the variety. They understand the terpenes. A lot of the regular care physicians that do this do not. There is a handful of QMPs that actually do. There's a large amount that don't. But the pharmacists, they understand the medication, and they understand. I mean, when I have a question about a patient, I send them to a pharmacist because they know the products are out there. They can tell you what pharmacies you can get them at. They will tell you if it's at their pharmacy. They will tell you if it's at another one. And that's something that has been consistent throughout the program. I have never sent a patient to a pharmacist and had them only recommend their pharmacy's products because they don't own any of the pharmacy. Their job is to take care of patients, and that's the schooling that they were trained in. So they are the specialist here in Utah 9 times out of 10, and so it wouldn't be odd for them to continue that. So anyway, yeah, basically that's our recommendation, is just to allow these collaborative practice agreements between pharmacists and the recommending physician, to just kind of be that middleman, check the diagnosis codes, make sure that there's no contraindications, which is something that they can naturally do because of their education, and then onboard them onto the EVS, removing the main cost and keeping these lower income patients that are struggling to pay for this, or just people that maybe don't have the money to renew, keep them able to renew and keep them on the Utah program.
Awesome. Thanks, guys. Appreciate you. I just wanted to respond to the letter that we received. I speak just from my position on the board. I'm not speaking for anyone else on the board. In relation to the letter, I'll let them provide the responses if they want to, once we open it to discussion. But there's been some concerns raised over whether it be patient safety and quality of care, the scope of a PMP's practice, some regulatory and compliance risks as it relates to the continued federal legality of cannabis, potential misuse, and ethical concerns, and then some conflicts of interest. I'll start with the federal law. Yes, cannabis does remain legal under federal law. Anyone in this room is probably subject to federal prosecution on some level for what we do. I can tell you though that it is in the federal law that they cannot spend federal resources to come and prosecute anyone that is involved in state legal medical cannabis business. That has been an amendment that has been included with the federal budget for many years now. It's had different names over the years. I think at one point it was Robocker Farm, it was Robocker Blue now, what it is now. So I think a little bit of that is somewhat overblown. Of course, doctors, QMPs are face the same risks as a PMP would for recommending medical cannabis. We as operators face the same risks as well for trafficking, right? So I think some of that is not necessarily well placed, because that is a risk that we've all chosen to accept, to either be a patient or someone that works in this industry or touches this industry. As far as patient safety and quality of care and some of these other things, that's the whole reason for a collaborative practice agreement, right? It will spell out the exact terms and conditions of the relationship between the PMP and the QMP. Dr. Morgan last meeting did, he expressed some concerns, and I believe all of those concerns could be taken care of in a collaborative practice agreement. You spell out exactly under what conditions a PMP would be allowed to renew a medical cannabis card for the QMP patient. So I think some of those things can all be handled under a collaborative practice agreement. The idea of ethical concerns and conflicts of interest, I think those same questions could be posed to the QMPs as well, just in the other direction, right? You know what I mean? It's easy to say people are driven by money, people are driven by profit, but people are also driven by the same ethical concerns. And I think any suggestion that a PMP, as a medical provider, a licensed pharmacist in the state of Utah, or a licensed physician in the state of Utah, would be more beholden to the profits of their business than a QMP, I think is not well taken in my opinion. And I think really, you know, at bottom, you know, and I know the survey didn't get to this, and I hope in future years it does. We know, anecdotally, you heard Des say it, we know from our own experience as operators, that there are patients leaving the program because they cannot afford to just simply be a patient. Now, are there other reasons patients are leaving the program? Absolutely. Do we as operators own some of that? Absolutely. This market analysis is not something we're taking lightly, right? And we understand that there's a part for us to play in this as well. We do understand there are some patients that while they feel comfortable trying to afford the medicine, they do not feel comfortable being able to access the program either initially or really to renew. And I think, you know, Mr. Anderson asked some questions about why do we think we've seen such a jump in patients in the last few months? There's also been a big effort to get it out there and to do patient drives and to bring patients to the program. But it also does not hurt that patients are not having to renew every 6 months and pay that cost, right? We've seen a correlation between the number of patients coming in, also the number of patients not dropping out. Those graphs that you guys share, you know, you can see those things. And so at the end of the day, all we're really trying to do is provide an avenue by which an RMP that feels comfortable with it can enter into a collaborative practice agreement with the pharmacy. I can't stress enough that this is not a requirement. So if Empathetics, if Kindly, or if any of you other providers that are here today are not interested in entering into those collaborative practice agreements, there's no requirement that you have. Just like there's no requirement that you have to do a 1-year renewal, right? This is just an option to try to bring costs down for, for patients. And I honestly can say, if you look across the country, you can look at a state like New York, you look at a state like Delaware and Maine, they're actively making changes around the way cannabis is recommended, right? They are doing away with qualifying conditions lists, right? They are doing away with the idea of registering as a QMP and allowing anyone, you know, with the controlled substance license to be able to recommend medical cannabis. What they're trying to do is normalize it as a healthcare treatment option for people. And so that's just further what we're really doing here. We're not saying, hey, if this gets recommended and this gets passed into law, you have to enter into a collaborative practice agreement. Again, it allows that to be up to you. And then even if you choose to enter into one, you can have it be a 50-page document, just like the contracts that we've all signed in our lives that are too long to read, right? But then there's some people that may feel comfortable doing a much shorter agreement, right? You know, but that's what we're just trying to do, is leave that, make that an option, not a requirement, but an option for those QMPs that feel comfortable and for those pharmacies that would be willing to do it. And again, the entirety of the PMP's activity will be controlled by the terms and conditions of the practice agreement. They won't be allowed to go outside of that. So if the QMP wants to have really strict control, they're going to do that. If they want to trust the PMP a little bit in a working relationship, they can do that too. So again, the ultimate goal here is to try to bring costs down for for patients in that level. So with that, I'll open up to board discussion and we'll move to public comment.
I do have a question. I'm asking, in a collaborative practice agreement with between an EMP and an RMP, would there be any requirement for that RMP to have any kind of a provider-patient relationship with those renewing through the PMP?
There's the initial requirement, you know, my understanding about the proposal is there's the initial requirement
But
like exists today.
right, but an ongoing patient-provider relationship. That PM,
Yeah,
the RMP doesn't have to be the same person as the initial QMP for the initial evaluation, right? So my concern, my question is what will be the requirement for an RMP in a controlled practice agreement to maintain an appropriate patient-provider relationship?
necessary, it's not that, right? If that's a requirement you wanted to have, it's either it's R&D, or, you know, for the pharmacies, you engage with that. And if they enter what agreements, I think it's still out there.
I think, you know, there's a lot of anecdotal evidence here it's been brought forward. I really enjoyed the survey that's done. It shows some issues with cost in terms of what patients are paying in state versus out of state. That is an issue. Seems to be a well-done survey. We don't have anything like that as far as PMPs. So I would like to see that before we make any further votes or anything like that. And I think we ought to really involve or get some additional input from other stakeholders, namely the UMA, the Physician Assistant Association here in Utah, as well as UNP. I have spoken with UNP, and I believe they would like to provide a position on this in terms of, because I know the Native Giants are by and large the largest percentage of UNP in the state. They deserve to have a voice in this as well. Now, it took me a bit to get a hold of the right individual. I actually just recently spoke with that 2 days ago. No, yesterday, I believe. And they would like to have a chance to weigh in on this. And I don't think 24 hours is enough time for them to get it out to their board. But I think this needs to be further discussed. And as time goes on, I think we have some time until the next legislative session to really flesh this out and get this right for to do this.
Dr. Forsythe, do you have any idea of your ability to survey around, you know, or even you, Rich? You know, obviously being more involved with RNPs and patients. Has there been any discussion about surveying, you know, patients regarding the cost of the card? I mean, we already do it. Nearly 40-some thousand patients, right, that have left the program. Have we taken a survey of those people to determine why they no longer have a medical cannabis card?
So so there's a survey that we do quarterly now, which is the QMPs, to ask them how much they're charging. And the results of that are posted on the website. And then a separate survey about asking why patients leave the program. We have not done that. And we can take a look at that, get back to the board, and let you know what that might be able to look like.
Did I misunderstand that you were recommending a survey of the QMBs
Yeah.
and a cost analysis and that?
I would like to see both.
Yes.
Particularly on the patient perspective on why they will leave the program. I mean, it's truly access either by initial card, acquiring initial card or renewal, or cost, or both. That's what I would like to see.
Sure.
Before we take this a whole lot further. And I know that I agree there's some changes that need to be made, but I would hate to make a decision based on very little evidence.
One thing I can take a look at is taking the data that we already gathered for the medical cannabis cost visit website. Because they already report the data. And I can find out when the next quarter report will be. And after that, I can take a look at the possibility of putting some analysis together and sharing that with the board.
Because you all would have contact information for a majority of those 46,000 patients for that program. So,
Oh, yeah, we do now.
email addresses for all.
Yeah, one thing we're very careful about is sending out information. We don't want to overuse the email addresses that we have. So we're always taking a look at that, especially for purposes of reaching out to people that no longer participate. Right. But we do have their contact information, that's true, right?
So you're saying this is something that can be done?
Yeah, it's feasible.
So next month, we'll report back to us some kind of what it may cost, how much time it might take, so those things, at least just some.
Yeah, I can look into it and get back to you, to put it on your agenda.
Because I agree with you, that's why I asked the question, if you're regarding the analysis itself. I think it talks about what patients are paying for the medicine program. And we understand medicine is not inexpensive. But if you read that full analysis, part of what you see is the cross price pressures between the illicit market, adult, mature adult use market surrounding us, and then also a market we have yet to even talk about, the hemp derived market, right? That poses, that is playing under a different set of rules, not here in Utah, but federally, right? It's a federally legal, substance, right? And it can be sent across state lines, can be purchased online, both here in Utah and outside Utah. So I do think it's important to say, yes, we understand that medicine might not be the cheapest, but you also have to understand access is not just about your ability to afford the medicine, your ability to get in the program initially and stay in. So I would encourage any type of survey and data collective, because I think what we said to this point is you have some folks saying, well, patients can't afford to be patients. You have other folks saying, oh, well, I think they consumed, they took the medical cannabis and it helped to soothe their symptoms or cure their ailment, and now they no longer need medical cannabis. Or the third variety, which is medical cannabis just isn't for them. Well, which one of those three is it? It's a combination of the three, I assume. I would love to know some of that, some of that data, because we are looking at two different costs, right? What it costs to purchase the medicine, and then what it costs to be a patient, right? And we should have data on that.
And to be a patient, I think there's two costs there, the initial, the renewal cost, or the total annual cost, I guess, would be better than looking at. Because I know, by and large, the cost to initially obtain that usually is typically higher than the renewal fees involved. And we have had a pretty good job, as you mentioned, in the last 9 months, which tells me that the initial cost of getting in isn't completely worth it. There's a lot of people that would pay than have the actual program, which renew would probably be less than that on average. It's just who's willing to continue to pay to renew that versus who's not. When you add up, what was it, $107 per month on average that we're spending on the products, that's $1,200 a month. That kind of pales in comparison to the renewal fees. Yes, there are some renewal fees that would seem to be a little bit excessive. There's others that are not. But when you add up the total cost per year for renewal versus what people are paying on average for the product. When I say product, I'm talking about product block here in Utah. You can probably get almost twice the number of grams for the same price. In Wendell. I'd like to keep it in terms of the cost of product here versus outside, even though we can look at differences, that is what was outlined in the services.
We appreciate the hopes of normalization and access for sure, but I think my main concern would be what's to guarantee that the cost is low to guarantee access for patients that should have the program.
I think some of that could be, that would involve competition, if a lot of PMPs leave because they no longer are renewing because the patients go into PMPs. There are some PMPs, I guarantee you, that will leave the program. It's just not going to be worth the time to do this. Meaning the cost for initial renewals will probably go up because competition right down. But as long as we can keep a good healthy number of PMPs, I tell you, I compete with the other PMPs in cash value. I do. I look at their costs and make several adjustments over the last couple of years. But just remain competitive. The adjustments aren't huge, but they're not much.
I just mean in comparison to if we allow pharmacists
Okay.
to do renewals, what to guarantee that they'll meet the cost of those, so it's important.
Well, and Nanette, I think the answer is and maybe, so to be fair, the ones that I've talked to have said that they think that they could keep it around $20 to $50. They're hoping 20 to 40 is about what they're thinking they could do it for, because all they really need to do is make sure that they can pay somebody to access the EVS for them. So, but if they don't, let's say that they don't, this is something we can A, do away with easy. But B, it adds another layer of competitiveness even for the QMPs. So now the QMPs not are just looking at each other's prices, they're looking to compete with the other pharmacies, and with the pharmacists. So again, like I said, we can always reverse this, but also it just adds another layer of competition, adds another layer of people who could do this service. All we have to do is allow EVS access, and that seems to be the hardest part of this onboarding.
I have some questions. It's probably for JD and Des, but since you guys wrote this letter, but have you spoken to any recommending medical providers that are willing to enter into a practice agreement with a pharmacy?
So I have talked to my personal one just because he's somebody that, uses predominantly the LMP program. He doesn't want to recommend to a lot. His whole clinic does. He works for Intermountain. And they were absolutely interested, because what they don't want is they don't want to be, everybody in his clinic here in Cache Valley mostly uses the LMP program, because they don't want patients coming to them just specifically to get their cannabis card. They want to do all of their care, right? And so they said specifically they thought that it would be a model that they would use, because then they could, recommend to their 15 or enter into collaborative practice agreement. And then that they're not managing the EVS. They're not becoming a cannabis doctor. They're just handing it off. They're saying, yes, this is the diagnosis. Will you handle the education? Because a lot of doctors they think it's a great medication, but they don't feel like they have the basis of knowledge, even after the QMP course, to manage patients without a specialist. And so because he's like, this is not what we do all care. And so they like the idea of having somebody in their corner that's kind of managing it. So that's the only real like LMP group that I've spoken to about this, but at its front, they would enter into these collaborative practice agreements.
So let me get this right. The collaborative practice agreements proposed that the PMP can enter into a CPA with an LMP or a QMP, or does it need to be a QMP?
It would be an LMP, a QMP, a PMP. So anybody that would be a recommender. So that's why we put the RMP. So a recommending medical provider. Anybody who could recommend could enter into a collaborative practice agreement. There's no real reason to not allow an LMP to do this, because like they're doing it for 15 people and they're not going to ever be the specialist, but now they can rely on the pharmacist as the specialist to make sure that this patient is getting collaborative care.
So with a CPA between a PMP and an LMP, would that be limited to the 15 that they're currently allowed?
Yeah, because they're an LMP.
Contravention to our established law, right? Like you couldn't say, oh, hey, we're going to allow you to recommend renewal recommendation of medical cannabis for anxiety, right? You know what I mean? You would still have to follow general.
Oh, no. What I meant is if there's an existing CPA between a PMP and an LMP, currently an LMP can only have 15 under their license. That means that's under that CPA, that PMP can only renew or have 15 active underneath that LMP, right? It would have to have multiple CPAs with multiple providers to be able to take care of the number of renewals that they would be doing.
Yeah, you'd have a CPA with every single provider or clinic, right? That you would sign up with. In the LMP program, in a lot of ways, how it worked was kind of this, right? You know what I mean? Yes, it limited it to 15 patients, right? You can throw that out the window, put that aside for a minute. It really is the same idea, right? You were really leaving it, and even more, probably more expensive than a CPA you agreed to enter into, where it essentially left all of it up to the PMP. Determine dosing guidelines, determine dosing parameters, all of those things, right? So that relationship is kind of where this was born out of a little bit, is just trying to take it away from the UMPs who are less interested in renewing, or less interested in even doing, we're not going to do it for the initial recommendation, but less interested in dealing with the particular limit and giving it over to the PMP who interacts with the patient on a more regular
So
basis.
would there be a potential, for this to cost more for these patients if, an LMP or a QMP participating in a CPA with a PMP to require, regular follow-ups, charge for that, plus they get charged for the renewal by the PMP?
I mean,
Yeah.
it probably depends on what the collaborative
Well,
practice
to
student
get
is
it
goes
goes
out.
out, right? I'm not, I mean, Desiree might know somebody who's willing to do that. I'm pretty serious. I mean, this is personally speaking, I don't know of any QMPs or LMPs that would just do that and just with free range without needing to see that patient on a regular, fairly regular basis to ensure they remain appropriate to be the medical cannabis patient, meaning at least an annual physical examination, checking the blood pressure, something to ensure that things are kosher and that they can, the medical cannabis still can say fine. You know, it's medical and surgery history change. That's why we do annual physicals and do regular checkups. You know, I would be more like that. My one, my dad had patients doing this without my knowledge. Going to see getting reviewed by a PMP who has CPA by another LMP or QMP, and I'm not aware of it as the so I mean there are a lot of concerns here, but I think it definitely warrants continued discussion. I really would like to get UMP and UMA and the PA Association input on this as well.
So can you reach out to them and have them provide some input before next month's meeting? Or see when they think they can provide some input? Yes, this is a public meeting that's on the public notice website. This is public knowledge. And so, and this is not something that we just brought up 24 hours. Sure, right? I'll refute that comment. This is something that we talked about last month in our meeting, put it on the agenda for this month in the meeting, right? And are now discussing it again. So there was an opportunity for them to come last month. And there was also an opportunity for them to come this month. So I think if you do want that input, but I think that would be the challenge, is asking those folks to, to come. I've asked the people that I speak with, sure, to always, to the best they can to come in person. And we have a pharmacist here today who will speak, favorably, in relation to when we get to the public comment. So that would be my, my ask.
What about the 24-hour thing is the board of directors for UMP does not list their contact information on the website. So I had to reach out to their contact page. It took a while to get a response back and get the right individual for me to contact. I got that on Sunday. I waited until yesterday, probably on Father weekend. But we spoke yesterday and she was interested in learning more. So I think that I don't know about the UMA. I imagine that's
They're aware.
Stakeholder.
Right, and JD, I think something that'll be helpful to any stakeholder is having a written proposal. Public, that's on the record, and it's there now, the proposal that you and Des put together. So I think that will at least give, something that's written in writing, that's written a proposal, that can invite people to attach a proposal to, right? And at any time that people that like you or Des, who are the sponsors of this proposal, you as sponsors can reach out to any stakeholder you want, not just those that will support you, of course, right? So, and Chris can do that as a board member, but you as well, to help that the conversation and help inform the board and make sure they're getting the information that's helpful to them.
We may have some input on some revisions to the proposal, that we haven't thought of yet.
Yeah.
Refine the process.
Can we hear what Jimmy has to say too? His hand is up so politely.
Yes, no, for me, I'm kind of on the outside looking in, especially from the law enforcement perspective. I'm really excited to be part of this group because I learned so much and have a better understanding. But I will say this, for those people that aren't able or don't spend the time to attend these meetings or get a full understanding of these, specifically law enforcement community, when this program was set up, it's kind of set up with checks and balances. And so it's like, we're going to see a doctor and we're going to see a pharmacy. And so you have these checks and balances. And so whenever you eliminate one of those checks and balances, the perception is that we're just deregulating. And I can listen to this and I can understand, hey, this is it's a financial issue. We have patients that can't afford this care. And so that's why we're doing it. But if someone's not going to spend the time to do the research or read through of this stuff, I think a lot of it just looks like we're kind of eliminating those checks and balances. And so I just would kind of throw out there, has there been any kind of avenue to where we maybe look for funding for people that qualify or can't afford or need help? Yeah. Or yeah, I know. And so maybe that's something too that maybe we could throw more support behind. And I also apologize too, really quick, because it did take me a long time. I had my hand frozen for a minute. I got to leave at 4. And so I think we're going to get on to the background one later on in the agenda. And with that one too, doing the math, it's really kind of a small amount of money. And so I almost think that as far as the overall perspective, perception from law enforcement, if we could just get some funding, I looked at the background checks, it's probably, 15, maybe 12, $15,000 annually. If we could just get that funding instead of making it look like we're trying to deregulate. So we keep those checks and balances in place, but at the same time, we're lowering the cost of getting the medications to the people that need it. So anyway, thank you.
Thanks, Jim. Anything else from the board members before we open up to public comment?
I'd just like to feedback a little bit on this discussion about monitoring cardiovascular risk. I think also the risk of emerging mental health symptoms as well as monitoring the development of Parkinson's disorder is an important part of the future. There may be a PNP wedding and I find that it raises concerns for me in that.
And I think the only thing I would say is that could be required as part of the collective practice. I think that's the thing we keep going back to. All of these concerns and the guardrails that we want to put in, will spend all these spelled out in the collaborative practice agreement. That's the point of the collaborative practice agreement, is to spell out a contractual relationship under which you are willing to allow the PDP to do our medical recognition.
And I understand that, but at the same time, I don't know that it can be. And I'm not a pharmacist, so this is sort of a mental health specialist position. I don't know that they have the same qualification diagnostically to recognize the symptoms and how to diagnostic interview.
Rich, could you tell me what she just said? Because I can pretty much only hear you. And so can you summarize that?
Right, so the concern was just about the training, that the pharmacists do not have the training to do a diagnostic review relating to someone's mental health. And for example, if they had psychosis or some condition that really contraindicates with taking medical cannabis, especially those products that have a high amount of THC.
I think we might want to hear from a pharmacist on that, because the medical cannabis pharmacists, I have gotten better education and information on them on what terpenes should be avoided if you have the possibility or the genetic disposition to psychosis. I have never been able to get that from a QMP. So is there somebody in the room that could speak to that?
Yeah, and I think unless we have more board discussion, I do want to open it up for public comment, so we'll probably get to that.
I just have one more on there. I mean, as I was looking through this, I mean, we currently, collaborative practice screening is allowed, right, under any statute. I mean, essentially, I don't know what we're trying to get at, that's something that's saying, we're putting our rubber stamp on saying we prove that the pharmacists allowed, but you know, mechanics for it, right? Because can they currently enter into an agreement?
Not under the Medical Cannabis Act, and we've had our attorney take a look at that.
So the benefit, it does tell that you cannot.
Well, it doesn't specifically say you can't go collaborative practice agreement. It says it's got to be a QMP because of renewal.
That's a full statute change. Now, right. Does this then in turn a pharmacist who's only going to be, who's now is going to be renewing these licenses in these cards? Are they now essentially some kind of a quasi recommending medical provider? If they're not going to be meeting with their QMP, they're only meeting with the pharmacist, are they now recommending medical providers? Okay, when it comes to the pharmacist side of the pharmacist world, I'm not going to say I need full understanding, but what I read is I think they can recommend certain types of medications or drugs as a pharmacist. I'm concerned we're putting them at liability.
But I think that environmental chosen to treat pharmacists differently than medical cannabis program. I don't think pharmacists traditionally can set dosing guidelines and dosing parameters and things like that, right? They're generally dispensing the medication, right? When I go to Walgreens, I don't talk to the pharmacist about what dose, right? And like what milligrams does the pill is going to be, what I can and can't take, right? We treated pharmacists differently as part of the medical cannabis program. And I think what we've recognized is that they are more likely to become experts on it. It's not to say that the QMPs aren't experts themselves. It's because of the daily work these QMPs are doing that they have greater expertise. So we trusted them to make decisions around dosing guidelines and dosing parameters. So I think we've already chosen as a state, public policy is dictated that we've chosen to allow pharmacists in the medical cannabis context to go beyond what a traditional pharmacist will.
Now, with that out of necessity due to the fact that cannabis is illegal.
Probably have to ask the legislature.
I mean, well, I understand, I'm just trying to understand like the legality of what we're asking pharmacists to do. I mean, I understand on the patient side of the cost, it can be outrageous for someone to do the cost of the I have employees that get their medical cards that they have doctors who refuse to do anything past 6 months. So we try to proactively try and help them find a new QMP. Because we talk, he feels that's what's important, he wants it. And again, it's just, he raises his prices on the bills. And that's what he's looking at, instead of helping get access to more affordable price points. Again, but that beside the point, I mean, I think for me, really what I'm understanding, I have no problem with the clinical practice agreement, the way it's written. I think it helps. I think that there is actions there. It's just, as a board, if we're looking for a statute change, is this because, I get to your point where the pharmacist is knowledgeable, they understand. They weren't asked, a doctor typically does dosing and does recommending when it comes to normal script. Most doctors, even today, don't understand what cannabis can or cannot do. And so we have relied heavily on pharmacists. Or we at a point in the market where we can start pushing back on some of these doctors and saying, if you want to be a QMP, you need to have a little bit more further education. You need to understand a little bit more about how cannabis can help patients. So that instead of just giving a recommending letter, you're now actually doing the dose. We're doing more. I mean, is that the direction we'd like to see this program get?
I think we received a memorandum in February, right, that it was talking about patients' trust in pharmacists, and they outranked recommending providers. So I just want to reiterate that study, and it's right there for patients. It's really it that they trust the pharmacists more than even a recommended provider.
Anything else from the board? Because I think you have at least three here in the audience to comment.
I have concerns with the potential for pharmacists to be able to do equivalent diagnostic analysis for things like substance use disorder. I think even if they are able to monitor the basics of cardiovascular function, I'm not sure that they have the necessary training to think of it from a broader standpoint and apply it to overall health of the individual in the same capacity as a physician because of the differential treatment. I think potentially a better use would be of our time would be to look at where the breakdown in the LMP program occurred and how we can support that program rather than shifting and changing the renewal potential. I don't think that the practice agreements that we have throughout the country and throughout the state where, we can do vaccinations and it's very if this, then this necessarily apply to cannabis medicine. So I don't know if I'm comfortable at this point. I am not a pharmacist, but I do not see, direct correlation between the training, between the pharmacy program and the medical programs, to be able to, say they're equivalent.
Okay, anything from the board? Okay, we'll go ahead and open it up to the public comment. First on the list is, looks like it's Mindy. So if you can, please come to the table, state your name and your affiliation, and then you can stay 2 minutes to make your comment.
Okay, so I'm Mindy and I'm a pharmacist from Beehive Pharmacy. I've been part of the program for pretty much the whole entire time we've had a program. First, I want to first address some of the, I want to respond to some of the comments from you. We do already, as pharmacists, I already monitor for cannabis use disorder. I spend a lot of my time talking about tolerance and decreasing usage. And as far as the cardiovascular risk, I have concerns for that as well. I really want this program to incentivize primary care physicians to manage all medications, including cannabis. I want it to be free. $300 a year in the proposal, that was the amount of time or the amount of cost per year. That is a huge financial burden. So $300 just to have the opportunity to use a state medical program is not okay. My motivation for this change is to really help these patients afford their medicine. And I can tell you that Beehive will be a zero or very minimal cost. And I have talked to 7 other pharmacies who say the exact same thing. We are not doing this to take on more work or to still to increase profits. We are doing this to keep the program successful and keep people inside the program. PMPs do have the skills, education, and an experience to work along with a primary healthcare provider. So I want to stress that we're not diagnosing anything. I agree that we do not have any skills to diagnose qualifying conditions. We also, but one thing we can do, and we've all, pharmacists will learn in school how to take a very detailed medical history. We can screen for cannabis use disorder the exact same way that QMP can, and it's a simple questionnaire, and I have access to that. We can certainly do that as part of the collaborative practice agreement. We can ask questions about pregnancy, psychosis, all those things, and I don't want the complicated patients. Oh, can I have more time, please, JD? Okay. Let's see. I really appreciate the QMPs and the ones who specialize in cannabis-only medicine. They have really been instrumental for this program. We will always need QMPs. They're very complicated patients out there with mental health issues that a pharmacist will never be able to handle by themselves. What we're trying to do is just lower the price for those easy patients that they don't need a 6-month follow-up. And we've had this program for over 3 years. And I think that every single healthcare provider with a controlled substance license should know enough about cannabis to know the very simple contraindications. There's not very many, but they should be able to tell if a patient can either take it or not. They're probably not going to be able to give specific diagnoses or specific recommendations, and that's why we need a pharmacist. Can I have 2 more minutes, please?
We'll give you 1.
1 more minute. Okay. So PMPs can definitely carry the burden of the EVS and the paperwork as long as they get a referral from that primary care physician. And what I'm envisioning, I think a program that involves that primary care physician that's managing all the medications and is just using the pharmacist as their expert to help them with the dosing is the kind of program that I want. I will keep our program more medical, something we've always, that all of us want. This change is going to improve access and remove all the financial burdens to those who can't afford the QMP fees. And I want to also stress that not every pharmacy has to do this. Not every pharmacist has to do this, but the ones that feel like they are skilled and able to do this, then I want to be there for those patients. And Brigham City is a very low income town, and there's a clinic, a medical clinic. Anyone who gets a cannabis referral from there They send them to the specialized
Okay, sorry
QMP.
to be.
Okay.
Yeah.
Okay, thank you.
Thanks for your time. Next on the list is Nicholas Thompson Bob. Please state your full name and your affiliation, and then please take 2 minutes to make your comment. If you'd like extra time, please ask for it after the expiration.
Absolutely. Thanks for giving me the opportunity to do a comment. As said, my name is Nicholas Thompson Baugh. I'm from Empathetics. We're one of the biggest medical cannabis companies in the state of Utah. Medical providers, group of providers. We have clinics from Ogden down to St. George. My worry is in the attempt to keep people in the program that we're probably going to bring down the level of patient care, because there's no other prescription of this magnitude that we would give a patient that length of prescription for that length of time. And my other chief worry is, how are there going to be enough pharmacists to properly care for these patients or assess these patients on a 6-month basis, 3-month basis, year basis? You know, if there's 750 QMPs in the state of Utah, how are we going to replace that workload with a pharmacist who can possibly gauge and take care of those patients at the same level of ability or even at half that ability? And a great example of that would be in course of time, I have patients who go to a pharmacy now and they'll wait over an hour to purchase medicine, let alone the concept of if you have to meet with a pharmacist outside of your regular doctor. And so even if that provider is willing to enter into an agreement, I don't know if the agreement better serves that patient than them seeing their provider. And with that being said, you know, cost notwithstanding, I don't know how necessarily that will better serve a patient. And so maybe there can be looked at cost analysis in lots of different ways versus their medicine versus their provider or different things, or different state subsidies or things like that. So I think there's a lot of possibilities that we can do something, but I just don't know that it serves the patient. So maybe that's a question to pose to the board and just in general. Thank you.
All right, Tim Pickett.
Hello, my name is Tim Pickett. I'm with Kindly MD. I'm the author of the letter that was submitted to the Policy Advisory Board, signed by myself and some APPs and Dr. Corey Andon. I do have that letter out to Dr. Ward, who's indicated and I won't speak for him as far as his opposition to this proposal. Our concerns, I'd like to just address quickly some of the things that were brought up in the presentation from affordability. We have seen a decrease in price from QMP services across the years of the service being offered to patients. We also see patients under contracts with Select Health, Medicare, Medicaid, specifically Blue Cross Blue Shield, United, and Cigna. And we recommend medical cannabis. We believe that the affordability issue is a non-issue. Because as more primary care providers are seeing these patients, that issue is there. We also see patients for free that are under a program that apply to a free program that we offer. We also collaborate with other primary care providers in that regard. I would correct Dez's next. I would also correct Desiree's comment that it is required to see a pharmacist. Under the law, that's not true. Only if the provider does not provide dosing and delivery recommendations is that required. There are times when the pharmacist does not require. Additionally, under a CPA, there isn't a known CPA that we can find that would allow a pharmacist to renew a prescription of Schedule 3, Schedule 2, or certainly Schedule 1 across the United States. This would be a unique system and put everybody at significant risk. May I have 1 more minute?
Sure.
We believe that the cost of the QMP evaluation is a cost of medical care that we provide. We believe that we should, I would recommend that this board look at ways to bolster the QMP program instead of looking at ways to reduce the quality of care that we provide. We're already under audit from the Department of Health. There was a recent bulletin that was put out last week that increases our liability with regard to this program. So we're under a lot of pressure from the industry and, and a lot of liability for this program. And patients already pay 43% more. $2.5 million more per month is spent here on legal product than if they purchased out of state, according to the thing. And finally, I think that the program would be moving backwards and isolating pharmacists as the only experts and not incorporating primary care physicians into this program.
Thanks. Maybe one more.
Jamie and Joyce. You might want.
Okay, Jamie UT will go ahead and unmute you. Please introduce yourself. Yeah, sorry, the sign up sheet's already been signed. If we have time, we'll get to you after we take so Jamie will unmute you. Please introduce yourself, your full name and your affiliation, and take 2 minutes to make your comment.
Hey, my name is Daniel Rawlings. I'm a QMP. I just had a couple thoughts. So one, I've worked in an academic setting. I've used CPAs. I think pharmacists are amazing. They can be so beneficial in patient care. I've never had a CPA where a pharmacist could actually refill medications. So that's what this feels like to me, is not like an interchange where I would use it where they could change to a cheaper kind of medication, change brands to get something that's more affordable for the patient. This is actually having a pharmacist act as a provider and decide to refill a patient's medication. So I don't know if that's even legal, one. And then two, I hope I can share this example. So I saw a patient for a card. The time of issuing adds to the cost, but is also like a protective measure. So I saw someone who had overdosed once, overdosed on purpose, tried to commit suicide a second time, that came in for a card that I think needs to be followed very closely and managed very carefully. And if we're having patients like that be seen, I mean, like the whole cost thing is an issue there. So I don't think the CPA agreement would work in that setting. And then these higher risk patients end up having to pay more, even though I don't think they're like high income people necessarily. So those are a couple issues in my mind. And then like that $15 state fee is paid no matter when you renew. It's not like once a year. So that's another added cost that doesn't need to be there, just because I want to protect my patient and make sure they're doing okay in 3 months.
Excellent. Thanks for your comments. We'll turn to Chris, and I apologize. I bet you I'm going to butcher your last name. Shared or Shear? Did you drop off? Oh, no, there it is.
Can you hear me okay?
Yes, we can.
Okay, perfect. Thank you. My name's Chris Sheard. I am a pharmacist. I'm currently the chairperson of the Utah Board of Pharmacy. I would like to say these comments I'm about to make are not in any role on the Board of Pharmacy, but I just share that. So it's coming from a place of, I understand the rules around pharmacy law, but these are my personal comments, not on behalf of the Board of Pharmacy. I would like to just say that CPAs are very individualized between a pharmacist and a provider, and they can vary. So what one provider may require strict guidelines, another may have a little bit more lax. To Tim's comment about controlled substances, he's right that there aren't any CPAs out there, at least that I'm aware of either, that involve any C3 or C2 through C5, and that's because of DEA regulation. It's come before the board before, but the DEA has issued that if a pharmacist was to, even under a CPA, have anything to do with a controlled substance, they would need a DEA license, and we don't hold those as pharmacists. So we haven't been able to do CPAs with controlled substances. The other thing I would just like to say is, just from a purely operational standpoint, CPAs are under Utah's Pharmacy Practice Act and and outlined Utah Pharmacy Practice Act rule. So by doing this, all the rules and regulations regarding a CPA have to be compliant with the Pharmacy Practice Act. And currently pharmacists are not allowed to, it's unprofessional and unlawful conduct for a pharmacist to prescribe or dispense any Schedule I medication. So that I think that's why a large reason that this is under the Department of Agriculture and not under pharmacy, and pharmacy has been deliberately kept separate for that reason, is because it would fall under the Pharmacy Practice Act. It would, and if I can just ask for 1 minute as well, sorry, I'm trying to talk fast.
Yes, sir.
Thanks. It would also potentially open the door, even though DOPL and Division of Occupational Professional Licensing doesn't regulate or doesn't review CPAs, they don't have to get approval. It would open the door that if there's anything considered to be unlawful, harmful to patients, something like that, that would open the door that would allow DOPL then to go in and investigate the licensee, whether that be the provider and or the pharmacist, and hold them accountable to the Pharmacy Practice Act that they're doing. And if it was in fact dispensing a Schedule I or being involved in cannabis in that way, that again has been purposely kept out of the pharmacy rules and laws because it's against federal and our professional legal responsibilities in that way. So I know I kind of rushed through that, but hopefully that makes sense. Thank you for your time.
Thanks for your input, appreciate it. Any other comments on that? Okay. I think we'll go ahead and close public comment and bring it back to the board. And look, we obviously are in support of this proposal. Obviously, there's some things to consider. And I think given just kind of the variations of things that we need to consider, whether this is the right avenue to go, whether it's bolstering the LNP program, whether it's doing something like the state of New York has done, and some of these other states, are trying to, make it more of a traditional, kind of healthcare setting. It would be my recommendation that we were to table the item and come back to it in a future agenda to probably address some of these things, hopefully get some survey data, but then also involve some of these other medical providers. Because I think there's one thing I hear, and I don't want to put words in your mouth, but I think I do hear there's a general concern about how much patients are paying simply to be a patient. And there may be multiple ways that we can do that. So that would be my recommendation, but happy to take any kind of motion before we move on to our next agenda item.
JD, can I quickly just say too that something that we need to keep in mind that hasn't been brought up is that all of these QMPs could take insurance and to one degree or another have decided to in some situations, but mostly have decided to not take insurance. We could easily all agree to take insurance, all agree to accept Medicaid, all agree to take the patient's, like you were an actual doctor, and then just the patients, then this problem would go away. And that was Dez's migraine talking, but I meant it.
I think that point's absolutely well taken, right? And that's some of the things that we're discussing. Are there things that maybe, that we should be turning back towards the QMPs and seeing if there's a way, to Tim's point, it would be helpful QMPs. Well, maybe this is part of it. We find the ways so they can take insurance. We find ways to incentivize them to take insurance. But there's multiple ways to bring the cost down. This is just one that was, that's been proposed. So I think this conversation is worth pursuing further. So I would hate to take any kind of motion today and end the conversation here. But again, if anyone has, if anyone does want to make a motion on the proposal, we can take it. If not, I'm happy to make the motion to table it for a future meeting.
I'll always make the motion at the table to talk for the future meeting.
All right, I'll second the motion. We take a roll call on this.
Tim Anderson.
Yeah.
Nanette Resney. Yay. Tammy Clark. Yes. Desiree Hennessy.
Yes.
Jimmy Higgs.
So sorry, it was a little mumbled. Just so I clarify, the motion was just to discuss this later. Is that what I'm doing?
Future meeting.
Yes.
J.D. Larison.
Yes.
Chris Morgan.
Yes.
Matthew Page,
Yes.
Missy Smith.
Yes.
All right, and that motion passes unanimously. All right, hopefully we'll turn into an issue that won't have nearly as much input, although I will say this, I do appreciate it. It's one of the things I most appreciate about this board and being able to sit on it, and even if I didn't sit on it, being able to attend. The amount of people here in the room, the amount of testimony that's given, the amount of work that goes into it, we might not always agree on what we think the best solutions are for the Utah program, but I think it's very important to have these conversations, in public. I can't stress that, enough. So, all right, we will turn over to item number 6 on the agenda, which is around reducing the cost of caregiver and guardian cards. Again, this is not necessarily a patient cost issue, but this is someone who's related to a patient who is being required to go through a background check that we don't even put patients through. So I can obtain a patient card and have, and have a criminal history, right? But I can't obtain a caregiver card if I have that same criminal history. And I understand some of the concerns. I'm sure we'll hear some of those concerns from Jimmy, but I really want to turn it over to probably Nanette. And then Des, and then, if I need to support, I'm happy to, but I'd like to give Nanette, as a caregiver herself and as a patient, the ability to kind of talk through, some of the proposal and just highlight, kind of some of the burden it takes to be registered caregiver.
Yeah, well, it's pretty simple. Obviously, it's concise and quick. The COC imposes a $68.25 application fee for medical cannabis caregivers. That fee is comprised of $15 for the card fee and the $53.25 for the background check. DHHS has the authority to adjust that $15 card fee according to the regulations. The background check involves a $20 directed to DHHS Division of Licensing and $33.25 to the DLPC. The CMC doesn't control the cost of the background check, and also included in that pricing that is not incurred through the state or the CMC itself is the fingerprinting that is involved with having to do the background check, and that's outsourced to the patient, wherever they want to, or they can give or guardian, wherever they want to go get that fingerprinting done.
And just really quick, something else is just the driving there, taking off of work potentially to go get it done, right?
Yeah.
Yep.
There's a lot of time incurred on top of that, especially if you're a caregiver. I mean, that means we usually have in my case, a disabled child in tow, having to go do all of these things on top of it. So not only is it a financial burden, but it's the time and so 3/4 of the cost of a caregiver or guardian getting this card is incurred through doing the background check. So our proposal is that caregivers and guardians should pay no DHHS card fee. The caregiver, or for the caregivers, the patient will pay an additional $5 fee that's incurred on top of their card. And then background checks would be eliminated for caregivers and guardians and replaced with a yes or no checkbox regarding their criminal history, specifically travel and distribution.
And I believe, Des, and chiming here, I believe this is based upon the New Hampshire model, correct?
Some of it.
Caregivers.
Yeah. Loosely. No, and I can say, so to just give you a view of when we created this program, the conversation surrounding this caregiver card was what they wanted to avoid. Because we didn't know how this program was going to go, right? Like we didn't know, there was a lot. I mean, if you read 3001, right? Like it's very heavy on regulation and very small on like the actual cannabis program. So we were protecting against a lot of things. The concern here was that we were going to have people sign up to be caregivers and they were going to be using that to get product into the black. Well, we kind of solved that problem ourselves by keeping our costs so high that we can't compete with the black market, and no one is going to do that. So win-win, that's no longer really a concern. So and I'll be honest. So when Hestevan needed his medical cannabis card. I was not going to pay for this. I wasn't going to go get my background check done. Granted, it was like 2019, and getting your background check done during like a government shutdown or something that is like nearly impossible. So I just went and got my card and then was just giving it to him. Feel free to arrest me. I could use a break. So I don't think that this is, I don't think this is the concern. I think that diversion isn't going to be a problem. The caregivers that these patients are choosing, they're choosing someone that they trust. It's 9 times out of 10 like a family member or a close neighbor. That's a lot of times it's somebody that works inside of a rest home. These people are getting their family member or their friend their medications. That's what they're there for. I think that reducing, I mean, I think our biggest threat of diversion is doing something more like I did. Like, I'll just get my card and I'll get you the medication. So I think let's remove that. Let's just have the patient pay the extra $5 if they need a caregiver. And then the caregiver can just say, you know, we can put something if it's punishable by law or whatever, like they do on an application, like just say, if you're a felon and you've been caught selling drugs, please don't do this for your uncle, right?
Yeah, I actually have a question for Rich and then probably a question for Jimmy, and I'll be able to answer it. Rich, do you know how many of the current caregivers, or not current caregivers, the ones that were applied to be a caregiver, do you know how many have failed the background check?
I don't think, I can confirm that, but I don't have Katie here.
I have an answer as far as CMC staff that I asked, no one's been confirmed with a background check.
Okay, but the fact they have to pass it is a deterrent.
Of course, of course.
Yeah.
But they also don't necessarily, in the caregiver, is it similar failure points as like agents? Like a distribution charge?
Similar.
Like a felony of any kind, and then a distribution charge after the cannabis finding. So
I believe it's for the 2018 misdemeanor, that's a misdemeanor for drug distribution. But the other part of the law is if you've committed a felony related to drug distribution in the past 2 years, but if it has been at least 2 years since you have served a sentence, then that's waived.
yeah, and I actually did want to ask Jimmy a question, and I'll let him provide, you know, his comments as well. Jimmy, are you aware of any cases where a registered caregiver has, you know, since medical cannabis is legal in Utah, someone that's been registered as a caregiver has been prosecuted, not necessarily convicted, but prosecuted for drug distribution?
So I'm not aware of that, but I also didn't research that. So that's something I can definitely follow up and get to this group. I have to jump off in just probably 5 minutes. So just really quickly, I can give you just some numbers. We're probably doing an average of 250 of these a year. Obviously, DPS is a fee-based setup. With the way they work is, you know, they're not given general fund to staff, and so they rely on the fees to do this. But realistically, the cost involved in this for us is probably only $12,000 a year. And so again, if that's something to where, you know, we could fight for appropriations, $12,000 a year would enable us to do this for free for caregivers on, you know, just the volume's not there. So definitely something to look into. When I think about pulling them away, again, just the perception is deregulation, but at the same time, I think, you know, it makes a lot of sense to where the actual patients don't go through this process, just the caregivers do. And if we can show that it's really not being abused, I think that, you know, getting that data, I think would speak a lot. So that's all I really have to say, and I have to jump off. So any quick questions? If not, I got to leave. So
Thank you, Jimmy.
thanks, everybody.
All right, any more discussion from the board?
I do have one comment, you know, well, the caregivers, I think it should be incumbent on the QMPs to assess for possible diversion on the patients that have those caregivers. You know, we offer free drug screens, random drug screens on our caregivers. We don't charge them for that part of the service we provide for the patient as a medical cannabis. We have a discussion with those caregivers. If they want to be a caregiver, that they requested to do a random drug screening if there's even suspicion. I mean, we're not costing them a dime. If they come positive for THC and they do not have a medical cannabis card, then there would be another discussion on switching caregivers, because there's licensing diversion going on. Or we would not withdraw that patient's card. So I think there is some responsibility on the community's part to make sure caregivers are on diversion.
And you don't have the since you sit here today, that you're aware of.
We have not had a single positive. Yeah,
So do you put your caregivers through those trainings?
randomly, we've done, on suspicion, I think we've done 6 or 7, we've been very few cases. And they've all come up, so. But no, I think it's still, it's still something that should be evaluated, on regular basis and not, each one. For all patients. And we do ask our caregivers, some, for reading.
The proposal, that $5 proposed charge, what does that only cover? That would just be to cover the cost of the card?
To add that as a caregiver.
To add.
So the patient pays the $15 to their card, they pay an additional $5 to add here.
That would be covering the cost or so of putting that together. Okay.
Yeah, and there'd have to be, if we still are doing background checks, there would have to be some way of covering that additional cost,
Right.
53. Yeah,
If we're still doing it.
right. But if we weren't, one possibility is to random audit those that claim that they don't have the criminal history that would stop them from getting the caregiver card. They're attesting to it. And then we would use that $5 to help us cover the cost of the random audit that we would do using programs like Clear. There's some databases that do some of those searches.
Because you'd obviously have some kind of perjury or something.
Right.
Yeah, so, yeah, I mean, just like when you sign an affidavit, right, test something, you sign. Of perjury. So
Right.
that'd be pretty similar.
I mean, I would actually kind of love to see this broken apart. I mean, a guardian card is how you say it's right, any participation of the agent. That's it's classified as, and you can also be a character, it's the same. Go through the same process, anybody is under 18, they can't get entry into the forest. So, guardian card, I mean, is it possible that when we figure out where we go at, we separate that out, if you're getting your guardian card, there's only, I don't know how many under 18 patients there are. Based off some numbers I saw, like 42 last year or something, got the guardian card. I mean, it's such a small number.
It's a small group.
I think looking at that side is if you have a child who needs medical cannabis function, their parents should have to pay for a card. It shouldn't be, they're already paying for participation. They should just come with a guardian card regardless of background or not. I mean, it's the guardian there. I think as far as the proposal on the caregiver side, I think those costs can get down again. I do know that there's no, for the first renewal, there is no fee for a caregiver card. This is kind of right, I was reading online. It's usually on the 1-year renewal, but they then start paying again. So I think there's ways we can help save the money. And I think the background, the checkbox, a lot of people do use that. I think in researching this, I know half of the medical states require a background. So it's already 50%. Utah's not at the high end of pricing to begin with. But it is such a small number in the bucket. I mean, is this something that the Center for Medical Cannabis, like we talked about finding a budget to cover a cost? Is this something that can be set aside to use to help alleviate that cost?
That's something we would take a look at.
Now, I mean,
Yeah.
I can't remember who can, anyone can be a caregiver. Right, there's no limitation on a caregiver.
Well, you have to be over 18.
Just what, age.
Right. Right. Yeah, and the background check, get that ID.
If you are curious,
Basic stuff.
prospective caregivers are asked on the application what their relationship is to the patient. Do I hear about that?
You know, I would assume hopefully you're going to utilize for hospice care.
So I have the numbers for 386 of them. 298 reported they were family members. 44 were parents or guardians. 25 were friends, and 19 were other.
I think the majority of their someone that would otherwise probably be prosecuted for like. No, and then there are some people. All the time. Some guardians, et cetera. Yes. Yes, caregivers. So, yeah, I mean, I think it's just, this is just another pricey little one. We're just trying to do. There's other ways to ensure someone is not a criminal. I we should do that. And if we're not putting our holders themselves, people that are actually going to consume cannabis through some kind of background check, I think, and we don't have any evidence that caregivers are running wild and diverting and distributing drugs, especially when you've heard that the vast majority are direct family members. I say the term no-brainer, but this seems like a no-brainer to be in. Other states are moving in this direction. I think this is just another attempt to normalize, cannabis. And also too, I think you do have, I've had at least one person reach out to me and talk to me about being kind of a professional caregiver, right? With hospice care and stuff, and having to go through a background check for every one of your patients. You know what I mean? It eventually adds up, for those people as well. And I think if we are seeing usefulness in cannabis, especially one of the biggest segments of the population using cannabis right now is baby boomers, right? And they're getting into that place where they're going to be in assisted facilities, like under hospice care and these different things. To provide just one more hurdle for them to not be able to get their medication or have it administered to them, I just think it makes little to no sense, especially where if I look, had Jimmy given me a different answer, right? Or had Rich said to me, he didn't have to think about it and said, oh yeah, we've had 40 caregivers, fail the background check, right? Then yeah, maybe I'd have concerns, or if it was on TV that a bunch of cannabis, sold from our pharmacy was being diverted. I think I'd have more concerns. So with that, if there's anything more from the board, great. If not, we do have one person who's here in the room who'd like to comment on this. And
I want to make one more comment or two more comments. Well, and I wish Jimmy had stayed on because I wanted to say this earlier and then he said he had to go. I wanted him to be on for this so he could say if he remembered the same thing. But I did a class with the gang unit and the officers in. You were there. What department was that, JD?
I tried to block that from my memory, but I do remember doing that presentation with you. It was a gang unit presentation out at the cultural community center, or wherever we were.
Yeah, but it was all of the officers in, was it all of Utah or all of what parts of Utah? It was there was a lot of people. Anyway, we asked those officers if there was a problem with them making arrests and it was ever product from the Utah medical cannabis market. We never got a yes. In 2 days, we never got a yes. I talked to the heads of the departments. We never got a yes. So that's, they said it was always black market. It was always from California. They were not having a problem. They had not seen it. So that also gave us kind of some pause to realize that this might be okay. On the topic of caregivers, professional caregivers, I didn't hear all of what you said, JD, so sorry if this is redundant. But we do have a couple professional paid end-of-life doulas or hospice workers or whatever that have become professional caregivers. And I did remove this. Brandon, did that hurt your brain because it was like end-of-life doulas or something else?
Sorry.
I'm like, so we do have a couple paid professional caregivers that aren't related, that if it's like they take a group of hospice patients that don't have family support and then they're kind of put on their case as like social workers, whatever, and they have chosen to become medical cannabis caregivers. In that situation, I find it's appropriate to maybe attach their background check to this or, you know, maybe have them pay the full fee. That's, you know, up for discussion as well. But we do have some professional caregivers unrelated. It is a job they do. I think, you know, having them do a background check makes sense, or, you know, having them obviously pay their own $15 fee, something like that makes you know, is kind of a different category for me than a family member or a trusted friend.
Okay, one more comment from the board before we go to public comment. Okay, we'll go ahead and go to the public. Looks like Tim Pickett.
And just a reminder to anybody speaking, try to speak loud. Des, how are we doing with you being able to hear?
It pretty much sounds like you guys are all fish in a tank, but other than that, like about every fourth word is fine.
Okay. Well, that's not good enough. No. So.
Trying to be positive.
Just another reason to come in person.
Yeah.
I know.
Sorry.
Sorry, my name is Tim Pickett. I represent Kindly MD, a group of, providers in a clinic that we see quite a few. And that's why I wanted to make a comment, because we do actually see quite a few of these caregiver situations. We have some patients in facilities that require caregivers. And we agree that the system is burdensome. Guardians of children are oftentimes, in our experience, lower income, and so this is a financial burden to them. We feel like the caregivers are diverting in a lot of ways. You know, somebody will get a card and then just give it to somebody else. That's problematic in a facility when when their parent goes into the facility and now they have to navigate that system. So reducing the burden and the convolutedness of this system would be helpful. And we haven't had, we don't test. It's interesting to test your caregivers, but we don't test any, and we haven't had any problems with our caregivers as far as like the system goes. So we're totally in support of reducing the burden here and just making this a lot easier. We think that would be much more legal.
Excellent, thanks. So, would you see the next one? No. Okay, it doesn't look like we have anybody online. So go ahead and close the comment and bring it back to the board during the session. If not, we can take action. So yeah, I'll continue on.
Rich, is there any concern maybe from staff level about not having additional fee for a guardian or caregiver from someone that's under the age of 18?
Let me research that. We can see how it impacts our budget and get back to you. But like Matt said, it's not a significant amount. I think it was you that we're talking about the fee, right?
At least that was the guardian side.
Right, the guardian side.
I assume somebody to carry the cost.
Right. Right, but it would be an ongoing expense, and my expectation would be that over time it would increase because it's easier to get, but also the program grows. So with that comes bigger impact, but with that also comes bigger revenue as the program grows. So, right, but I think in a future meeting, I can report back and share some additional specifics about that. Any concern about the impact financially?
I mean, I like your comment that if you've already, you've got to be able to keep going this anyway. And so that caregiver or guardian is essentially the guardian.
Yeah.
So, okay.
Yeah, I think it's important to realize, so if there's, I suppose, two options here. So there's a possibility of removing the criminal background check completely and not requiring it. And then it may make sense to allow the DHHS to continue to do an audit using a software that would help us do that audit, right? So there's still some additional cost in that respect. But then there's the second option of still requiring the criminal background check and the DHHS or some other source having to cover that difference. Because it will still cost money to do the criminal background check.
Quick questions. What comes with $15 guardian?
So that helps us cost the software cost of being able to apply for a card online and there are software costs and we gotta cover those somehow. That helps cover that cost. There's an online application fee in the EBS that allows us to make it possible for people to just apply online.
It's not a card though.
Well, there's a card that's emailed, right? And they have to have that with them when they purchase.
Oh,
Yeah.
Are the costs associated with, all the costs you just talked about, are the same costs associated with a caregiver card? Like you do the exact same things to issue a caregiver card that you do, background check notwithstanding, but the same exact things you would to issue a patient card?
Similar, yeah, it's just we've got an application that's online that someone fills out, we get information, right? And then that's submitted and our system is set up so it's able to confirm that, hey, if this A, B, and C is provided, then we're issuing the card. Now it's a little bit different with caregivers because we have to wait for a criminal background check to pass before we issue the card. And so that does require a little bit of a manual review. It's going to be less time in the new software that we're building, but there's still some additional work that has to be done on the caregiver for that reason of the criminal background check. But the fee is still the same between the patient and the.
So assuming we got rid of the background check, it obviously takes out those costs associated with manual, any sort of manual, review you have to do once you get the background check back. If we remove that, it takes those costs out, right?
Sure, but then if we still do an audit, there's not as much cost, but a cost of completing an audit and the cost of paying for a software that allows us to do the audit, where we're getting public records about criminal history of the individuals that are audited.
So don't want to put you on the spot, I'm going to. Do you think if we left it at $15 for the caregiver card where it is currently, that would cover these additional costs to audits?
That's a good question. I can take a look at that internally, get back to the board about that. I think one thing to keep in mind is we set all these fees at the beginning of the program based on projections, right? And we knew that when we started, we just estimated costs, ballpark, did our best to estimate. We're still right now paying back a loan to the general fund. And also we've got a year right now that we're going through where we have very high software costs because of the change to the new software that will be a better situation for everyone, but an increase in fees. So for software. So we're in a bit of a, what I would call a transition period as it relates to our budget expenses. I think for things to normalize, it'll take a year or two after the software is put into place. And when we're, like, for example, right now, we're paying 2 software companies, one, our current one, and the second one to build a new system, right? So we're able to, I think over time, normalize when we're only paying for one software and less expenses, obviously, during that period that allow us to adjust things a little bit better. And over time, we look at the fees, we evaluate the fees, the legislature looks at them, and the board can always make suggestions for decreasing fees, like on this one, for example. And then we make adjustments on our end as needed. If the legislature requires we reduce something, we adjust on our end and respond as, because, obviously they carry the purse and they make the decisions about that.
And the fees are not necessarily, not decided by the legislature, right? They give you the ability to set the fee related to.
Right, but we report them and then they have the ability to veto them.
Of course,
Right.
But so in theory today, we could we could vote to recommend to remove the background check requirement for caregivers and guardians and not reach the fee issue, right? We could reach the fee issue at a later meeting.
Oh, yeah.
And maybe have some more data to, and some answers to kind of support whether the current $15 fee, because what I hate to do is vote to reduce it to 5, which is nice, but then have that create a budget issue, for you all. So that's how I would tend to see is bifurcate the 2 issues, do away with the background check. I mean, but we do away with the background check, or at least vote on whether we'll do away with it or not, and then we can come back and deal with fees once we have some more information, I think that probably makes sense.
The point of this is on, yeah, of course, a suggestion on, this may not be a very popular one, but, you know, I know what my fee is, as a QMP every couple of years. It's not that much. Perhaps we could survey QMPs and PMPs to see if they will support a small increase in their fees every couple of years. Not much, but, let's see if they would support something like that in order to offset the cost and get these caregivers, eliminate the caregivers and guardian fees altogether. And that would provide some revenue and without overburdening the QMPs and PMPs.
Sure. And that may not be necessary, but
Sure.
that's a possibility, you're right, because that's within the department's abilities to increase one fee and decrease another. And the board would be welcome to make a recommendation regarding that.
I'm always look at any avenues, you know, but if we could vote on the background and get the rest of the adjust later.
Yeah, all right, that sounds, yeah, sounds fine. Motion, yeah, we'll make it, next meeting. Yeah. I know, it's just close.
Well, then I guess I'll propose that we eliminate the 53.75 caregiver and guardian card background check.
Check box. I think probably what we need to say is we want to remove the background check requirement. For caregivers and guardians, it probably make more.
Yes.
But ignore it. I think you're very tough. Even that, I just want to make sure we go far enough. So, I'll make a motion that we recommend to the legislature that we remove the requirement for caregivers and guardians to undergo a background check in order to obtain a guardian or caregiver card. And that we replace the requirement for a background check with a yes or no checkbox regarding criminal history related to drug trafficking or distribution.
And I'll second that.
All right, we have a motion and a second. And you can take a roll call.
Yeah. No. This is remove the background check requirement for caregiver and guardian card in order to obtain a card that would replace the requirement for a background check with a checkbox indicating that they have not been engaged with drug
For distribution.
We specify convicted at the state or federal levels, because that's the existing
Yes,
criteria.
yes, so convicted state or federal level of crime for drug distribution.
It's just attesting to that they comply with the current requirement, whatever the specifics of that is. And
Yeah.
that's a summary of what it.
Yeah, we can make that clarify.
Ken Anderson,
Yes.
Nana Perezzi, Candy Hart, yes, Desiree Hennessy,
Yes.
Vicky Lorenzen,
Yes.
Chris Morgan,
Yes.
Matthew Page,
Yes.
and Missy Smith.
Yes.
All right, I find that motion passes unanimously. I will make a follow-up motion. That I motion that we table the fee discussion for caregivers and guardians to a future meeting. We have a second for that motion. All right, the motion's been made and seconded. All those, let's take a roll call vote. Second, yes, what it's gonna be. All those in favor, please say aye. Aye. Any opposed? All right, I find that passes unanimously. Obviously, Jimmy has not been here, but we have. So that's what. Yeah, okay, now to the last substantive agenda item, and this is going to be more so for a discussion, so I doubt we will take up the remainder of our time. We want to just kind of preview this. I think mostly want to talk to Cody and Brandon just about logistics around rulemaking and rule implementation and stuff. So I just think, you know, this has changed a little bit, I think, over time as the rules have seemed to slow down a little bit. But I think the primary example of why we brought this forward for a board discussion was changes over packaging, right? There was a time where it seemed like a change to packaging was coming I don't know, to us as operators, it seemed like once a month, right? I know it wasn't that frequent. But it definitely seemed like it was something we couldn't stay ahead of. And I do know from talking to some operators, you know, saying tens of thousands of dollars, you know, was wasted on packaging. It's not an understatement. I think some are far north of that. But also too, just trying to be compliant and trying to be able to, I get it, if there's an emergency rule, right? There's nothing we can do about that, right? If something needs to be enacted on an emergency basis, well, then that just has to happen. But for some of these rules, it would be nice, and I guess where my questions go are, in reading the law, it sounds like a rule has to become effective 120 days after it's published. That's kind of that 4-month window they give you all to enact, you know, kind of enact rules. But I'm also wondering, just like you see in the statutes, and I couldn't remember if I've seen this rule before, but sometimes it'll say in statute, like beginning on January 1st, 2024, this is now, you know, a requirement. Or if there's a way to do that in rules, I think that would be preferable. But if not, at least, you know, trying to make rules, non-emergency rules, you know, effective, you know, at that 120-day mark to give us a chance to kind of catch up to some of these, because some rule changes are easy, right? Some of it's like, oh, you need to dot this I. It's like, oh, perfect. We might have already been doing that, you know, as a company, but changing packaging, you know what I mean, where you've got a bunch of money outlay and you've got, you know, obviously, you know, the more you buy, the cheaper it is. And the less money we have to spend as operators, the less money, you know, is passed on to the patient. And we want to give Matt a chance to chime in here as well as the cultivator and processor representative. But I just think that we see these rule changes coming. And even though I'm aware of them sitting on the board, I'm not sure everyone is. And I think a lot of times I've seen you guys send out follow-up memos that are like, hey, just a reminder, this rule went into, you know, effect, you know what I mean? So I feel like if there was maybe a little more lead time before rules became effective, I think it would be really, really helpful, because I'm not aware of anyone, I haven't heard anyone say, well, I'm just going to keep using that same packaging, right? Most people are like, I wanted to use the same packaging, and then it ends up putting stickers over things. I mean, you guys remember when there was the website stuff, right? You could put the stickers over, you could still see through, and you know what I mean? So it just seems like it would be nice to have that additional, additional time. And if it's something you guys can already build into the rules, you know, if you can say that this portion of the rule is going to be enforced as of this date, or just some sort of delayed enforcement, even if the rule is published and it's effective, delaying some of that enforcement to work with the operators.
Can I address that?
Of course, absolutely.
So to my knowledge, we're not able to delay enforcement in rules. Once it's submitted to the rules office, it goes into effect once it's published there. What we can do is just not submit it to the rules office.
You can delay it though.
Can we do it?
It depends on how the statute requires for it to do
Not
it.
forever, but
Right.
there's a period within which it would have to be filed. We can take a look at that later.
Yeah, pretty much what it is that, as you mentioned, there's 120 days, right? So if the statute goes into effect on May 1st, says you'll have rules for this, then you're pretty much stuck with that 120 days, right?
Yeah.
If there's an ability in the statute to say to go along with prolong that, we can do that in that matter. But then to your second point, we did work with several people as long as they came to us first on that. We do that quite often with rules to do that, to work with them and make sure, which is why there is probably some stickers and some stuff, but based on how far they wanted to go on changing it or even to move forward. And it's something we actually continue to do when we find some things and ask them specifically. Interesting enough, it's usually the ones that are complaining about this. They're the ones that we're which we're working with more. And we'd be proactive and ask them, how much inventory do you have? And what's the timeline to do this? So, yeah, that's stuff we can do, but we're not also a fan of also being out of compliance ourselves either.
So in like a rule, you couldn't put as of January 1, you can't do the same
Not
thing
unless
with
it's
the
in the
statute.
statute.
So if the statute delays the effective date or the implementation for when that, not when it becomes law, when it becomes enforceable, you then have that same leeway in rule.
Yeah, so and there'll be some examples that show up in the processing rules. We're going through the legislative changes because there was like a couple of Januaries and a May date that we're actually removing out of it because they were 2023 dates type thing. So there's those situations, but those were pretty much out of statute.
Okay, that makes sense.
But we implemented, as you guys know, the processor, cultivator, and pharmacy meetings that we hold quarterly to try to keep everybody up to date on that. As you noted, we've tried to reduce the number of rule changes. Very much, which some people think we don't actually like making these rule changes either. It's just a huge burden on us.
Well, yeah, and I can go through that. I expected this type of thing, right? And as you mentioned, JD, already, that we have to be in compliance and we're not with the legal requirements for the 120 days of legislative changes, which is why they come, right? Definitely not going to ignore the public or patient safety needs, which I think you mentioned in your portion about emergency rules and whatnot. But I went through all the rules that we did, and to your point, we admit that the very beginning of the program, there was changes, right? The cultivation changed 6 times in the 5 years that we've been here, right? The last time, there was done one time in 2022 in June, which would have been a legislative requested or needed change. One time in June of 2023, and it would have been a legislative needed change because of legislation again. As I mentioned earlier, not a plan to do that in 2024 unless we add radiation to that type of thing and say that growers want to do that. Processors, again, another 6 times. There was an emergency rule in 2020. I'm assuming that was for COVID and some things like that, as far as things that happened. That thing to allow industry to continue on. Again, 6 times overall. There was one in 2023 in June, or sorry, 2 in 23. One was in June. The legislative stuff, and then there was an industry request and some patient wants in October that was changed. So it was changed twice last year. The big one is quality assurance testing. It had 11 total changes and 5 emergency rules. Many were industry requests, right? Some things as how we tested and what was going to be tested was testing and cultivation or non-tellers processing. Some were COVID related, right? The labs couldn't get certain equipment, so we had to make some changes there so we could actually get product out to the patients. And then I think there was an artificially derived one, not just this most recent one, but also back with some D6010 stuff, maybe type of thing. But a lot of those were based on industry to not at least industry wants or so much as industry being able to move forward with the program type of situation. So yeah, that's by far the most was 11. Third-party labs was 5 times that we've changed that rule. Again, the last 2 were legislative things, one in 2022, one in 2023, not looking at changing anything. Currently, educational events have not been changed at all, but as I mentioned earlier, we'll probably add some pharmacy stuff to that during this next year. Academic research, one time back in 2021. Cannabis licensing has never been changed, and obviously pharmacy and couriers we've only had for a year, so they could speak to that one type of thing. We will have some legislative requirement change there. So we agree. JD's not off that there was at the very beginning of the program that was there type of thing, and as Brandon mentioned, as the person who's looking at these the most, I don't like it at all, but I think we're pretty close to a place where it's a 1-year thing unless there's some emergency or some concerning things.
Do you think there'd be a willingness to just follow that 120 days or be somewhat close to it?
I think it depends. Like I said, I mean, obviously there's going to be the industry needs that we've just done, right? And then also the patient and public safety concerns and things that we want to be at. But I think we're close enough to keep that done that we could do that. We've already put an internal policy in, with the exception again to your point on the emergency rule recently was to look at cannabinoids on a more spread out basis once a year, right? On both of our programs, just because the quick changes, as you mentioned, does cause it not only issues for us, but issues for as regulators, but issues for industry as well. So slowing that down, I think, does everybody get an understanding. That being said, there probably needs to be something put into place that says you just don't need to jump in and start doing stuff because it's not there. The whole thing should be slowed a little bit. That sometimes it's caused it, right? Someone goes and does something, the rest of us find out and go, "Ooh, we probably should look into that." So.
Yeah, I'll kind of bring it up is that as a processor, and speaking of those in the industry, that really the biggest headache was around packaging and labeling. That was a constant for the first year and a half. There was back and forth on changes, whether it was too colorful, not enough color, how big the font, small the font, high font. I mean, there's changes weekly almost to the point where, I mean, most of them were out of pack. which is easily. But when they're into actual printed packaging, maybe the JD is calling, maybe we're talking $10,000, $50,000 of packaging in one go. It's hundreds of thousands of packages that eventually use over the next year. I mean, I usually forecast any purchases 6 to 12 months, depending where we're at. I was actually going shorter than that for time. Concerns how it changes. However, I think it'd be working with the 12 bag, you have allowed us to be able to exhaust prior inventory, whether it was through use of stickers, or this, I mean, I think the big one was when it changed from what's qualified medical providers to recommending medical provider. We had lots of packaging that had to qualify on their still, so we were able to go through that and exhaust that package in order to remain compliant. I mean, I think the last change we had was January 1st, like turbines that was on there. Again, that's on the back panel, not necessarily a packaging change. I think the longer the runway for us to make changes, the better. I mean, again, I think we're in a unique position that we hear a lot of these changes before it happens. Those every 2 months we have these infiltrator and processor meetings. Depending on when you guys are working on those rule changes, you could be already 2 months behind from the rule change being put in place. And so for some people, they need a good 60 days to contact suppliers or whoever it is to get out there. So I think if there can be an industry-wide communication, saying, hey, here's some rule changes that we've done, a little more transparency on, hey, here's our proposed rule change. I try to let people know those changes that are going to happen. But whether or not it's not, it's up to them and how they want to respond and follow the rules. So I'm not in charge of the quality assurance or compliance.
We have the same issue.
You know, I get it.
A lot of this.
Yeah, so, yeah, and so I think that's, as long as we're doing what we can to get it out, that's on the individual processor. We're not here to make sure that I'm not their compliance officer. You're not our internal auditors. Although sometimes it feels like the inspectors can't be the auditors for us. We wish they would make my job easier. They just put all my compliance. Basically. But no, I appreciate that. I think for us, so the board understands, I mean, it can get burdensome if there's constant changes. There hasn't been anything drastic recently, but I think that doesn't stop that can't happen again. And so what we want is just to make sure that as rule changes come about, that the communication is there, that there is a runway for everyone to remain compliant. That does come in to be a patient safety issue. If labeling is not correct, if packaging is incorrect, it's a safety concern. So we just want to make sure that both foremost of everyone's thought.
Yeah, I think if we could move, I mean, I know you guys are usually have to have some form of removal within 120 days of the end of the session, right? You guys are ready to do that here, or 120 days after it goes into the law, right? If we could keep rule implementation to that one time a year outside of emergency rules, or something that just happens to come up that needs to be addressed, I think that would be advisable. And then trying to stick as close to that 120 days to when it becomes, effective, because then you will likely capture 2 of your meetings. You'll probably, 2 cultivator meetings, 2 processor meetings, and then I think the pharmacy meetings are now quarterly. At least have had one of those. I think that would just be, our advice. I mean, we didn't put it down for any type of board action. I'm also down to know. Just I had some questions for you guys. I had read that 140 requirement, but I didn't know if there was a way to also kind of like, kind of predate, or future things, when something becomes effective. But that's good to know. And I guess obviously part of law in the legislature for it seems like it's going to be a major change, where it's going to require you all to make rules to just say as of X date, this is when this becomes, effective.
Yeah, and just a couple little clarifications too. So 63G is the statute there, and it's actually 180 days. So it does give us a little bit more time to get those out, which might help. What my next comment was actually going to be is that I think that's like extremely doable, and that's probably our goal moving forward. Unless there's all of a sudden this major shift legislatively that says, just like now, I mean, I am a little bit worried about trying to get the closed door pharmacy one, because it's just a whole new thing type of deal. So I might have to push some things that are legislatively needed back a little farther just because of timelines, but I think the 6 months is probably more than I can get that done, no problem, but there's always that concern on my end. It's like you prioritize stuff. And for instance, the hemp bill have allowed that concentrate to be coming across state lines, and it went into effect upon the governor's signature, so that's what we did, right, first, right, this priority wise.
And those, I think those ones make sense, right? Like if they give you a short fuse, we understand those, right? It's the ones where there doesn't seem to be a public health emergency, right? It doesn't seem to warrant some quicker action, just, trying to give us as long of a fuse on that as possible, I think would be good. So I don't know if we'll come back and address this at a future meeting, but just, I think just so you guys could understand, so they know it's changed over time in the program, but sometimes these things seem super quick and it's, you're trying to get it in compliance, next thing you know, the inspector is showed up and we're like, hey, we're working on this, but that's never, it's never like, oh, we're working on it, you guys don't have inspections, right? So, and I understand what they do. So, yeah.
Since just one last comment from me, since all rules need to be reviewed by this board, we could just have this meeting once every 4 months.
I see it, I see it. I mean, you can take Dez's meeting, just attend virtually.
Cody, you're a genius.
No, and there may come time, where that's where the board feels, to be quite honest with you guys, there may not be much to it. But this is enough. I know we have one person that has public comment, anyone on the board have anything else on this one? Okay, we'll go ahead and take the public comment, Nicholas Thompson Bond.
Nicholas Thompson Bach from Empathetics Medical Cannabis Clinics once again. Which obviously this has been talked about and exhausted, and I've spoken to the board on this topic before, but I'm really excited about the concept of some of these things that we're moving forward of like the terpene profile as far as like getting that education for patients, because some of these patients are very excited about some of these changes to the packaging, which I get from a processor standpoint, that could be very frustrating, but patients want to know and understand their medicine that much better. And to that perspective, the QMPs want to know and understand how to educate those patients. So if a patient was to bring in their medicine and this was it, they want to be able to dissect it and go, okay, patient, you have a really hard time with pain. This one has beta caryophyllene in it, has myrcene. So, I mean, the more education we can put out there, and I've said many times, that the more that processors can advertise so that a patient can understand that medicine, and the processor probably understands their medicine better than that pharmacy, unless that's one of their internal products. I just think that those things are so beneficial to the patient and the public at large. I don't think that there's any danger to the public by people understanding medicine better. Thank you for your time.
Thanks, Dan. And I can say, we as a pharmacy, we're providing that terpene information, on the part, right? We want patients to know this same information. I don't think we bring this conversation up to say, it's the onerous burden. It's just, it's the frequency, right? And trying to stretch that out the best we can. It doesn't otherwise affect patient health and safety. And it's just a rule change that's being made, substantive or even, even technical. I'd love to just see as long of a fuse as possible so we can maintain, compliance. So we're happy to provide this information. So one online, one. All right, looks like we have one online. M. Morrison, we'll go ahead and unmute you. Please state your name and any affiliation you have, and then take 2 minutes to make your comment. Mr. or Ms. Morrison, you've been unmuted. Please state your name and your affiliation and take 2 minutes to make your comment. Okay, well, we'll go ahead and, now they're unmuted.
Can you guys hear me?
Yes, we can.
Oh, there we go. Okay. So this is Justin Ariola. Sorry, this is my admin computer. So Life Elevator Processing, we're the Healy brand. I just wanted to say a couple of things in regard to packaging compliance. One being that it seems like MJ is less and less supportive. towards things like data keys and things that were being required to add to compliance labels. And so I guess my thought add here would be, what is the department doing, or what are we thinking about doing as these things continue to develop and we get into the transition with Salesforce? How is the department going to be with things that you guys are asking for, but we cannot get MJ to provide? And kind of the feedback that we've been told is, hey, get it. You need to get a second party label software and then add it into the compliance label somehow. But that requires us to have some tie-in between the secondary labeling system and the MJ label that comes out from the compliance side. And so looking at what the department's going to do with these issues as they go up. And I know we've got one specific issue with you guys right now. And then the other thing that I wanted to talk about was with terpenes and other product information. When we were talking about adding the terpene information and testing, we had talked about allowing pharmacies to have basically a QR code in the lobby that would tie to specific product testing profiles, whether like if I had a third-party testing for terpenes or something that I wanted to link to, that I could put that and tie it to that QR code and kind of work with the pharmacies to do that from a patient information standpoint. And I was curious if we were going to move in that direction, or how does the department and this board look at that from a, is this advertising versus is this education standpoint?
Thanks, Justin. I mean, I do know currently you can use a QR code to link to a COA currently, right? To provide that terpene information. So QR codes are currently allowed on packaging. How would you guys feel about being able to use QR codes, within the pharmacy, or not necessarily maybe on the packaging, but allowing patients to scan QR codes to access, a library of COAs for a producer's products?
Especially for COAs, we're in favor of giving information to patients. So.
And then to his second question, because I know we've had this issue, right? Whether it's THCO or any of those other cannabinoids that you all were testing for, I called you about the CBTC. That is the issue we're getting from MJ, right? And that's the response we get. I'm sure you guys get a similar response. But I think, our expectation is we're paying for a software that is not working, and to go to extra costs and expense. I just really hope this is a top priority for the new software.
It's really the impetus for the new software. Like the contract is expiring anyway, but the regulators need more control over that system, and we need better access to make these changes in the software. We were paying immense amounts of money for every single little change that we made.
And having to wait several months.
And then waiting, 6 months to a year sometimes, for these changes to be enacted. So we're feeling the pain, probably not quite as much as you guys. I understand it's a huge burden on the processors, pharmacies, and cultivators, but we feel the pain too. And so it is a major priority in your system, just to have something more flexible. It's not going to be perfect. I don't want anybody to get their hopes up that we're going to have this right out of the gate. There's going to be some struggles here, but at least we'll have the ability to control our risk.
But I guess I did want to ask one question just generally about the ICS transition. I know you all, from your perspective, have right now a tentative go live date for the June. Rich, is the go live date for EBS similar to that?
It's gotta be.
Okay, it's gotta be. And then for you all, going back to you, the ICS go live date for pharmacies, is that also early June, or is that going to be later in the summer?
The plan is to have it all go live at the same time.
So that training that will go on next month, that is going to be training for both the supply side of our business as well as the demand side of our business?
It's that the DHHS training, because we are going to separate out, because there's information for the pharmacies that is going to be relevant to the producers.
So there'll be like EBS training, right? Obviously.
Separate.
And then there'll be ICS training that encompasses both pharmacies and couriers or religious pharmacies. And then you'll have separate training for supply. Those will be going on at the same time.
Not the exact.
Not the exact same time, but I'm saying, yes, okay. Yeah, I just want a couple of things because it just seemed clear recently. So I just thought I'd ask because it seemed like the pharmacies were maybe doing it, but because when we asked, I can't remember who his name is, but we asked him, he said, oh, this is just testing for the supply side. I was like, we want the ICS to go live for everyone, so I appreciate that. Any further discussion from the board? Otherwise, we can talk about next meeting's agenda and then we'll have it ready. Okay, so next meeting, we'll meet on Thursday, I believe. And, you know, look forward, you know, the topics for the meeting, our list has gotten pretty scant. So I would love it if some of you all could provide some recommendations for either future meetings or really next month's meeting. It would be really helpful. So we'll be meeting with that. I think as far as the tracker goes, we've gone through on the majority of them.
We'll try to have a little.
We can put this up on the screen if we like. On additional pharmacy and cultivator licenses, I think that those are kind of holdover items from last year towards the beginning of the board. Recommendations to the Center for Medical Cannabis Research, collaborative education between state agencies and industry regarding black market products.
Yeah, I think one thing we could probably discuss next month is whether we want, you know, now that we're going to put the onus more on board members and the members of the public to kind of provide some of these written documents, we could talk about possibly putting together some subcommittees and see what interest we might have as a board next month. I think that might be good to do, because I think just the way we're constituted right now, we just prove it more difficult this month. We thought also let me know how much work Trevor really has to do it, and was so appreciative. So I think that's one, but if someone sees something on here that we want to for sure have on the agenda, speak now. If not, please send us some ideas for, you know, for next month.
What would be the board's opinion of maybe doing a more in-depth cost analysis? Because a lot of the times we're discussing burdens on patients, but would it be helpful to either as a subcommittee or as a board, look more closely at the costs that the patients are incurring, and even that the QMPs are incurring, and see if there's recommendations we can make, because I'm not sure, I mean, the fee schedules that we learned today were new information to me. So I'm sure I will learn things by going through this process. So we might be able to find additional costs that we might be able to reduce on patients.
Yeah, I think that's a worthwhile agenda. Maybe it'll be more of a discussion that kind of first time around. We can talk with what abilities you all have to help us figure out what all the costs are, because I think that's worthwhile. I mean, I think a deeper dive just generally to the program and where it's going, sure, you know, from all angles, it's definitely worthwhile. So yeah, I think we could put that on there, just, you know, kind of starting to just, you know, round table what costs we should be looking at, where we can run that information and that stuff as well. So.
Yeah. And also just to build on that a little bit, if ever any board member has specific questions that they'd like answered to DHHS, UDAP, you're welcome to reach out to staff that, you know, in our case, Trevor, Ivy Cody, for UDAP, to ask questions about those specifics. And sometimes, you know, if a board member feels more comfortable discussing it freely during a private conversation, they're welcome to do that. That anyone could call and ask questions like that. You could work that out. One thing that we did a little bit different that we didn't do in the past, but had been done in prep for this meeting, is that Trevor reached out to each board member individually to answer questions, to share information, right?
Correct.
And hopefully that was helpful, and we'll continue to do that. And yeah.
Well, similarly with the trainings that are required, like with the QMP training that's required, with the exponential increase in research that's now being done on cannabis products, how often is that training reevaluated and updated? And is that something we could consider looking at areas for expansion or refocusing?
Yeah, that's something that we are taking a look at internally at the department, but as it relates to the QMP courses that are required, we're looking at updating that and adding some topics that we feel like aren't specifically named, and so they sometimes aren't specifically covered in the 4 optional trainings. I mean, training's required, but there's 4 options for it. And so board members could make that an agenda item And, you know, we would try to make sure that the board members have, here's the rules that set the standard for the training that's required for QMPs, for PMPs, for pharmacy agents. Because they have to do,
My thought was maybe with the onset of the Center for Medical Cannabis at the university, it could lead to something like a continuing education event that could possibly defer costs.
Right.
For renewals of some of the licensing.
sure. Yeah, that's a good idea. We can add that to the agenda and we could come prepared with other answers to questions that you have about that possibility.
I think it would make sense to do that cost analysis, figure out all of the costs, and then figure out where you might be able to reduce those costs, right? Figure out.
Can't balance a budget until you understand.
Okay, well, I think we have at least two items, subcommittees, and then also talking about this cost analysis. We're trying to get to a place where we only do 3 substantive items, so we can see this. Works out about perfect. So if someone has another one, great. If not, we may choose one from the list. But please, by all means, I'd love to see Kent submit us, not to put Kent on the spot, but I'd love to see Kent as a member of the public submit something to us that there might be some public concern or something that, that you're curious about from a public, perspective. Because I've said this, since the board started, and I've had the privilege to be the chair of the board, and it's but this board is ours as well, right? We are a public, we're a public policy advisory board. And while we have responded to requests from the legislature, we waited on rules and stuff. I'd love to see us continue to that's not, it's not just about the regulation, but cost. Stuff is down there. If you have anything else, we will take the most popular motions. Yeah, move to adjourn. Motion to adjourn. I'll second it. All those in favor? Aye. Any opposed? Thanks, everyone.